第一次召开的梅麦高压专题会。这次会议受到国内外各界的高度关注。这次会议学术内容安排非常丰富，既有理论，又有实践经验，有前沿成果，也有应用的一些实验室的诊疗方面的技术。可以说也是在新冠这样的情况下，又一次学术盛宴。希望大家呢能够认真的聆听，积极的参与互动，提高我们的学术技术水平，更好的为患者服务。本次大会得到了兰州大学第一医院、南方医科大学南方医院、中国梅麦高压诊断和检测研究组的大力支持，得到了相关专家的大力支持，得到了有关爱心企业的大力支持。在此，我表示衷心感谢。预祝大会圆满成功。
Thank you, Professor Xiaolong Qi. Always with passion for work, passion for APASL, passion for all of us with the meeting. Now I would like to invite Professor Xiaolong Qi to give us a speech. Xiaolong, please.
Good morning, ladies and gentlemen, colleagues and friends. I'm Xiaolong Qi, a Chinese hepatologist who put all my effort and energy in the field of portal hypertension. As the founder and chair of CHES, it is my great honor to hold the APASL single topic conference on portal hypertension today. Portal hypertension, these words came in my life 12 years ago. I have to say during the past decades, this guy, portal hypertension, appears more frequently than my parents. That's my real life and first love, just as the Serene said. In 2016, we founded a national platform focused on the portal hypertension research, formerly known as the Chinese Portal Hypertension Diagnosis and Monitoring Study Group, named CHES. And very soon tomorrow, we will have a new name as the Chinese Portal Hypertension Alliance, CHES again. Our interest always focuses on the patient-oriented clinical and translational research. And currently, we have launched 50 multi-center trials and published several important results in top journals like Journal of Hepatology, Lancet Infectious Disease, Lancet Gastrohepatology, Gut Hepatology International, etc. These important results was also highlighted in the Lancet and Nature. In 2018, CHES formulated the first version of consensus on clinical application of a hepatic venous pressure gradient in China. And in 2019, we participated in the APASL consensus guideline on acute on chronic liver failure. And in 2020, CHES formulated the experts consensus on full cost management of portal hypertension during the COVID-19 post-pandemic period. Today, CHES has received not only participation and support from more than 300 university hospitals in China, but also effectively promoted the academic cooperation to the overseas countries like India, Japan, Brazil, Thailand, Indonesia, Turkey, France, Italy, Switzerland, Spain, and United States. As I mentioned, CHES always focuses on the portal hypertension research. However, our vision is far beyond portal hypertension and far beyond research. Beyond portal hypertension, and it became a portal for the knowledge sharing and information exchange among Chinese experts. A portal for new concept and technology of China to the world, and a portal for the data sharing and the communication among colleagues worldwide. Beyond the research and became patient care, CHES is always thinking, what kind of research is truly needed for patients? What kind of research is truly helpful to improve care? What kind of research is truly written on our motherland? To make the chess vision come true, we really need the support of some heroes like academician, chairman, and dean. But more importantly, we need every ordinary researchers, every ordinary physicians who truly love the field and put all her energy and all her passion in the field of portal hypertension. Last but not least, I would like to thank Professor Jinling Ho, who always support me when I was a junior fellow in his great team. I would like to thank academician Jia Hongdong, academician Fu Shen Wang, and academician Hui Shuang, and Professor George Liao, Professor Ji Dongjia, Professor Lai Wei, and Professor Hong You for all your kind support. I really appreciate Dr. Shiv Sarin and APASL colleagues, and Professor Xi Zhongyang and the CFHPC colleagues to organize and contribute this great conference on portal hypertension. And lastly, I hope you all enjoy the following 2 days in Guangzhou, China. Thank you very much. Thank you.
Thank you, Professor Xiaolong Qi. Now I would like to invite Professor Fu Shen Wang to give us a speech on stage. Please, Fu Shen.
Dear the president of this conference, dear all professors, good morning. It's my great pleasure to be here. As you know, since the epidemic of COVID-19, this is the first time I came out from Beijing to be here to attend this very interesting conference. For example, last month, I have several meetings I want to attend, but I have the temporary duties. I cannot attend. It's very sorry. But today, I'm very happy to be here to attend this wonderful meeting, the APASL Single Topic Conference 2020, portal hypertension and end-stage liver disease. Also, I express my thanks to the president, Professor Xiaolong Qi, and also I express my sincere thanks to Professor Jinling Ho for your kind invitation. I'm very happy to be here because I can see a lot of friends like Professor Ji Dongjia, Professor Wei Lai, Professor Jinling Ho, Professor Yu Hong, and Professor Song Jian, as well the Professor Tong Gaojun we met last night, and then all their colleagues to be here. First, I have a very deep impression of the agenda of this conference. I think the agenda is this conference is wonderful because many talk and well-known experts will give their wonderful talks, very interesting talks in the field of portal hypertension and then end-stage liver diseases. The second, I hope all the participants enjoy their wonderful meeting, their wonderful talks. Also enjoy your stay in the beautiful flower city, Guangzhou. At last, I would express my sincere thanks to the steering committee president, Professor Sharon and Professor Omada. And I just a moment ago, I saw Professor George Law as well, the president of the APASL, the Professor Tongwati. And then also I express my sincere thanks to all of you. 我也最后用一句中文的话，祝大家还在节日期间节日快乐。祝我们的大会圆满成功。谢谢。
Thank you very much, Professor Fu Shen Wang. Now, we also prepared Young Investigator Award to encourage our young generations to pay more attention and research and make more excellent achievements for our country and for whole world. Let's welcome 4 investigators to the stage. And also, I would like to invite Professor Xiaolong Yang, Professor Fu Seng Wang, and Professor Gao Junteng, our distinguished guest, Professor Gao Jun here, to present the awards to our 4 young investigators. Please. Investigator award. Name. Ladies and gentlemen, today we gather here to celebrate the coming of APASL Single Topic Conference 2020. We also express special thanks and respect to our medical workers because of your contribution in fighting against COVID-19. We come back to normal work and life. Next, let's move to the state-of-art session and welcome Professor Jia to moderate lectures from Professor Sarin from India. Professor Jidong Jia, thank you.
Oh, good morning. I have to speak English because this is officially a APASL single topic meeting. And now, in addition to the on-site audience, there are a lot of audience in other countries. So although my English never as good as my Chinese and Shandong Pudong Hua, but I have to speak this a little bit awkward English. Now it's a good honor for me to introduce Professor Sarin to give a lecture on the portal hypertension in liver failure, a new dimension. As I already know, Professor Sarin is a leading scientist and leading physician in the field of portal hypertension in Asia and Pacific as well as in the world. Now he is a chairman of the Institute of Liver and Biliary Sciences, New Delhi, India. Now, please welcome Professor Sarin to give the state of lecture. Please. Professor.
thank Professor Xiaolong and the organizing committee for inviting me. I bring greetings from the Institute of Liver and Biliary Sciences. I wish I was there personally to see this beautiful city and the excellent work being done by the teams in China. I have nothing to disclose except that we have very bright young faculty and very bright residents. I would try and cover a rather under-recognized area of portal hypertension in liver failure. First, to see what happens in a healthy liver, and then what happens in a chronic liver disease. So when you have a patient who has got liver failure, you will look into whether he has normal liver disease, normal liver, gets an acute insult and acute liver failure. I am not discussing decompensated cirrhosis. On the other hand, if somebody has chronic liver disease or has cirrhosis and gets an acute hepatic insult and gets jaundice and possibly ascites, and I want to show you this right now, why we are thinking about ascites. And this is acute on chronic liver failure by ARC by APASL. So I am going to discuss with you acute liver failure and acute on chronic liver failure and why liver failure causes portal hypertension. We start with a case, 41-year male farmer who was on antihypertensive with no addiction, had jaundice of 2 weeks with loss of appetite, painless progressive jaundice, no cola color urine, no history of transfusion, and history of complementary alternative medicine. Examination showed a BMI of 28, deep icterus, abdomen showed soft, non-tender liver, spleen not palpable, no fluid. What is the syndromic diagnosis? This is, of course, severe hepatocellular jaundice. And possibilities we kept were it could be viral, HAV, HEV, or autoimmune hepatitis with a superimposed drug-induced liver injury because he took drugs indigenous after the development of jaundice. His labs showed that he had a bilirubin of 32. INR was not bad, 1.58, but it was raised. Ultrasound showed echogenicity, no free fluid. CT abdomen showed mild hepatomegaly and mild splenomegaly, periportal and gallbladder wall edema, acute liver parenchymal injury. He was ANA positive. We normally do in all such patients a transjugular biopsy and liver pressure. And this patient, though no varices, had an HVPG of 15 millimeter. This is the biopsy which shows you that patient had a confluent necrosis, massive, and also had infiltration by plasma cells, neutrophils, and lymphoreticular stains were positive, bile duct proliferation is there, and had venulitis. The diagnosis was acute hepatitis with bridging necrosis with early fibrosis. So our patient, we thought, had severe autoimmune hepatitis flare, had a pressure of 15 millimeter, and he developed portal hypertension, that is HVPG of 15 due to acute liver injury, bridging necrosis, early fibrosis, acute portal hypertension. This is a stage before ascites is developed. This is actually a pre-ACLF where ascites has not developed. Bilirubin is 32. This patient was managed conservatively. He was given steroids, bilirubin decreased, INR decreased. A repeat biopsy done after 3 months and a liver pressure biopsy showed regression of bridging necrosis and HVPG from 15 came down to 7. The patient had transient portal hypertension. Acute portal hypertension, which occurs in a normal or near normal liver, is something which can complicate an ALF It can result in ascites. If we had not given steroid, this patient would probably have gone and become worse. And it can also be a result of massive cellular necrosis causing intrahepatic sinusoidal blocks. It's like an SOS. And there were no or maybe small varices, and there is a gradient. In this study in hepatology, way back in 89, 66 patients were taken with BA drug toxicity or indeterminate. Now, HVPG up to 20, and here is the collapse area percentage, 10%, 20%, 30%. You see that if the collapse is 30% or so, pressures are higher than when the collapsed area are less than 10%. Clearly shows that portal hypertension, sinusoidal collapse are related. In another study, 25 acute liver failure patients were taken. Their mean HVPG was 12.8. Ascites out of 15 was seen in 15 of the patients, and their gradient was higher from 12.8 to 15. Renal failure, those patients had a higher pressure gradient. It shows you that HVPG in ALF can go as high as 20 to 25 millimeter. And the reticulin collapse as percentage area correlates with HVPG. Let's say collapse area is 30 and you will have pressures close to 15 millimeter. In this very study also, no sinusoidal fibrosis or nodular regeneration, extensive necrosis, reticulin collapse. Importantly, no difference in survivors and non-survivors. This is a very recent study just published 2 years ago, in which necrosis was correlated with HVPG in ALF. Now here, you can see the necrosis is much more. Let's say 50%, 40%, and pressures have gone to 10 or 12. Now, whether there is a difference between survivors and non-survivors, not. The mean pressure is around 7 to 8, and it is not too high. But what is important and is significant is percentage necrosis correlates with HV. So what I want to highlight is necrosis of the cells in acute liver failure with sinusoidal obstruction can produce acute rise in portal pressures. Now, this is an animal study, and this animal study way back in 97 shows that if you have a galactosamine-induced animal model of ALF, after 24 hours, the mean arterial pressure goes down. This is systemic vascular dilatation, cardiac output increases, the total peripheral resistance decreases, and hepatic arterial resistance, portal venous resistance. All these are features of an acute portal hypertension, which develops in 24 hours of an acute liver failure seen in animals due to galactosamine. So I would like to summarize this part: pathophysiology of portal hypertension in ALF, severe hepatic injury, circulatory disturbance. And in 24 hours, you will have a decrease in mean arterial pressure, systemic vascular resistance with increased cardiac output. And these will lead to further necrosis, sinusoidal constriction, intrahepatic blockage, and an acute portal hypertension. So please remember, when you see an ALF, it is a rapid trailer of development of acute portal hypertension. But it leaves us with more questions. Should we give beta blockers? Is it reversible? I think so. Long-term sequel? Probably none. And the importance of HVPG in acute liver injury. This relates only to the extent, to the degree, but not with recovery. And there is enough data now that secondary to extensive necrosis leading to derangement in hepatic microcirculation can be reversed. And MARS, to some extent, can help in removal of these damage-associated molecular patterns. The second scenario for a portal hypertension can be a small for size syndrome. Now, this is, you give a new liver in a living donor liver transplant. Now, if the GRWR is less than 0.8, it's a healthy liver from a healthy donor, but this is the one which can lead to ascites, moderate to massive, within 7 days time. And if you have a GRW, or everyone knows graft weight to the recipient body weight, if it is less than 0.8, you may have a lower survival than those who have a good graft size. So don't have a small for size liver in a living donor program. I've discussed with you ALF, small for size. Now I'll discuss chronic liver disease or cirrhosis in which acute portal hypertension develops due to liver failure. One more time, I show you this diagram. I have discussed that patients who have CLD or cirrhosis, they get an acute insult. Now, this acute insult can manifest as a GI bleed. It can manifest as encephalopathy, ascites, hepatorenal, sepsis, or a combination. There can be close to 9 combinations of this. However, if this acute insult is hepatic and leads to jaundice followed by ascites, this is one form of decompensation. Then the APASL calls this as the ACL. And this is a homogeneous group. But if you take the West, if you take the cliff or anywhere else, you will have multiple. You may have a patient who has got sepsis, you may have ascites, but you may have no bilirubin rise, you may have kidney failure. So this is precisely a homogeneous group. And if you want to work on a homogeneous group, this is the way we propose. Why I'm telling you this is because this is reversible. Acute insult, you can stop ethanol, Hep B reactivation. Today, ethanol makes about 50%. 20 years ago, it was Hep B reactivation or autoimmune. There is an underlying chronic liver disease. You can diagnose it by endoscopy with varices, or if no varices, transjugular biopsy. And liver failure is defined with jaundice, which is more than 5, and coagulopathy with an INR of more than 1.5, which is followed by ascites or encephalopathy due to an acute portal hypertension. These are patients who present as acute insult or a liver failure. Now, ACLF is different than decompensated cirrhosis. Why? There is intense systemic inflammation, endotoxemia, increased nitric oxide or cytokines. Bilirubin levels are high, close to 15, 20. There is an impaired cardiac inotropic function, arterial hypotension, decreased oxygen delivery, a decreased vascular resistance, but intrahepatic resistance increases, portal pressure increases, and all these lead to a circulatory dysfunction. So to summarize this part, you have a systemic vascular resistance going down, cardiac output going up, and a rapid rise. Rapid means it can be 5 to 7 days. There is a HVPG increase, which may lead to ascites. Now here we show you why it occurs. This is a dynamic component. Stellate cells, endothelial cells, they become dysfunctional. Vessels do not relax. And in our earlier study, we have shown there is a rapid growth of varices. In fact, new varices can form in 4 to 6 weeks' time. And there is a rapid progression of varices, from no varices to new varices, from grade 1 to grade 2. And some patients might even bleed. So the question is, does treatment of acute portal hypertension in acute and chronic liver failure where underlying cirrhosis is there with beta blockers, does it reduce complications and improves the outcome in ACLF? And this is a very large study, unfortunately never got into the best journals because the definition is different, but you will see the message in this. These patients had a mean HVPG of 15. These patients had ascites, rapid onset within 4 weeks. And post-recovery, their HVPG levels came down. Here is another study. This study had 200 odd patients, excluded are 130. Then finally we have enrolled 136. Carvedilol was given to 60 and placebo to 70. Now, HVPG repeat could be done in 63 patients where carvedilol versus placebo were compared. It is extremely difficult to get a patient of ACLF in 3 months' time to have a repeat endoscopy, a repeat pressure, and a transtubular biopsy. Here is the data. So in both these groups, the liver pressures were about 18. 90 days, they came down. Remember, in ALF, the pressures in 3 months came down from almost 15 to 7. Here, from 19, they come down to 16. So the underlying chronic liver disease, the fibrotic liver, stays. The reduction was same in both carvedilol and placebo. What is important is when you give beta blockers in these patients, or especially those patients where spontaneously pressure decreased, in them varices did not grow. So if the pressure decreased by more than 20% HUPG, varices did not progress. In those, the pressures did not decrease, whether spontaneously or because of beta blockers, these patients didn't do well. Now here is carvedilol. Does it decrease the complications? SBP. Now this is carvedilol, the red, and the blue is placebo. By giving carvedilol, we were able to decrease development of SBP at day 28, pneumonia, and also the acute kidney injury. So what is important is reduction of pressure helps preventing complications of ACLF. Does it change into reduction in mortality? Yes. At 28 days, carvedilol compared to placebo had a better survival. It is 89.4% versus 75.7%. However, over 90 days, due to multiple reasons, these survival benefits reduced. So now the very last and very important part is acute onset ascites in ACLF. This ascites develops in about 2 weeks to 3 weeks. It is tense. It's anteroposterior. First time it develops. These patients have very high intra-abdominal pressure. They have severe coagulopathy and very high plasma renin activity. Normal being 4. These patients have PRA close to 20. Now, this study, which was published in Hepatology last year, we showed that first we must reduce only modest amount of acetic fluid called MVP, modest volume paracentesis, 3 to 4 liters, a slow tap, 4 to 6 hours. If you do this slow tap at only 3 to 4 hours, even then PICD developed in 72% of the, and sorry, the mortality was high. And those who developed PICD, but if you give albumin and prevent PICD, the mortality was low. So PICD develops even with modest volume paracentesis. Now here we show that if you have patients whom we have done either albumin or no albumin, you will see that at 7 days there is no major advantage. However, at 28 days, there is a distinct survival advantage. By giving albumin, you have 69% survival compared to none. However, 30% of the patients will still be dying despite giving albumin due to PICD and other. So ascites in ACLF is a huge challenge. What are the mechanisms? This is a very interesting study. When you give endotoxins, this is the blood pressure over time in minutes. This is just about 30 to 60 minutes. You will see blood pressure goes down. Now here the portal pressure goes up. So endotoxins decrease systemic but raise portal pressures. This is our animal model of portal hypertension, where we have a rabbit, and through the gastrosplenic vein which comes out through the nape of neck by a cannula, when you inject endotoxins, and these animals do develop portal hypertension, endotoxin induced portal hypertension. So let me summarize this part. Acute portal hypertension in liver failure, this is distinct. There is ascites, rapid growth of varices, endotoxins, cytokines. They are the major players. It could be reversible. and reduction in HVPG by beta blockers might be of benefit in preventing complications. Very briefly, I'll just touch venous obstruction syndromes, SOS, and acute HVOTO. Now, here is a patient who has an SOS syndrome. They have jaundice, they have got ascites, and it occurs. So many of our patients who come to us after drug injury or after hormone therapy can have SOS. Now here is an HVOTO where you can see that the hepatic veins are blocked, there is ascites, and you have a veno-venal collaterals. This patient had an HVOTO with an acute portal hypertension and liver failure. So let me summarize portal hypertension syndromes and liver failure. They can be in a normal liver, and this is ALF, or short for size, small for size syndromes. They can also occur in acute and chronic liver failure or sinusoidal obstruction syndrome. Generally, they have jaundice. Sinusoids are blocked due to blood or because of the damaged cells, hepatocytes. Many patients will have ascites and they have high HVPG or no varices. And there is a derangement of the hepatic microcirculation due to extensive necrosis and reticular collapse. You have to have a high index of suspicion of acute portal hypertension syndrome in patients with liver failure. Well, it has to be seen whether beta blockers can help. Of course, antibiotics. We have no data on simvastatin or use of anticoagulants. Well, if the patients are bad, you will have to have a liver transplant. With that, I would like to request everyone to look and support our Asian journal, Hepatology International. Thank you for your time and the opportunity.
Thanks for Professor Serene for the excellent talk, which raised a new concept, the acute increase in portal pressure. We just, due to the limitation, of course, we cannot have discussion. We just thank Professor Serene again. Okay, may Professor Dr. Lau?
Yes. Thank you, Professor Jidong, and so nice to see all my friends in China. So I'm stuck in Hong Kong because of the COVID-19, and I can see the collaborator Fusen Wang is here in Guangzhou. Without undue delay, I would like to introduce our next speaker, which is really heavyweight, Professor Paolo Angeli. Professor Angeli is now a very important person because he is the editor-in-chief of the Journal of Hepatology. And I think that we, especially the youngsters in China, in the regions, would like to have their paper accepted by the journal. And Professor Angeli is now the full professor of internal medicine and also head of the unit of internal medicine and hepatology of the University of Padova, Italy. And he led research groups working on pathophysiology and treatments of acute, chronic, and acute on chronic liver failures and on liver transplantation. He is also the present secretary of the International Clubs of Ascites and the authors of over 220 papers on international journals with peer reviewed, cited by ICR. His work is now well recognized in the field of management of ascites, bacterial infections, and acute kidney injury in patients with cirrhosis. And he is the major contributors for the guidelines of writings by the EASL. And without undue delay, I would like to have Professor Angeli to give his talk on ascites and renal impairment in patients with cirrhosis. And Professor Angeli, please.
Thank you very much for this kind invitation. I hope you can see my slides. Let me start saying that it is a big honor and a big pleasure for me to be here with you on a digital version, and I miss a lot the opportunity to meet you in person. So my duty today is to speak about some news about the management of ascites and acute kidney injury in patients with cirrhosis. And after my disclosure, I will do my job moving along this agenda. First, news in the pathophysiology of decompensation and organ failure in patients with cirrhosis. Then new in the developments in the management of ascites, and finally, new developments in the management of acute kidney injury. So let me move from the pathophysiology. Because, you know, for more than 30 years, we went on believing that the only driver of the complication of the liver disease was a progressive increase in portal hypertension, so a progressive derangement of hemodynamic state, and finally, a progressive increase in the grade of activation of vasoconstrictor and sodium retaining factors. This is surely true, but it is not completely true, because if we look to what happened in the late phase of decompensation, there is no further increase in the degree of activation of sodium retaining and vasoconstrictors factors. In addition, we can reduce the degree of activity of these factors, such as plasma renin activity, plasma concentration of aldosterone by means of vasoconstrictors and albumin, without affecting at all the clinical outcome, no reduction in the rate of development of complication, and no effect on survival. Finally, we learned, almost 7-8 years ago, that at any time, but particularly in patients with decompensated cirrhosis, a new syndrome may develop that is called acute chronic liver failure, that has an acute onset, is characterized by organ failures, and has a deep negative impact on survival. Well, now, if we look to patients who develop organ failures, you can see that they can develop organ failures even when the plasma renin concentration is within the normal range, but never if the circulating level of cytokines are within the normal range. So there is another factor that should be considered in the pathophysiology of organ failure, that is systemic inflammation. Systemic inflammation is a driver of organ failure, because if we consider a cohort of patients admitted to the hospital for an acute decompensation, and then we divided the cohort in two subgroups. On your right in red, the patient will develop organ failures. On your left in green, patient will not develop organ failure. You can see that the former group has a higher value of each pro-inflammatory cytokines. But you know, systemic inflammation is not only present in patients who develop organ failure, it is already present in patients without organ failure. So how early systemic inflammation starts along the course of the liver disease? I will say very early, because if we consider dynamics of decompensation, I spoke about acute decompensation, but let me say that there are also patients who develop progressively ascites without the need of any hospitalization. So we can call this condition as non-acute decompensation? Well, if we look even to non-acute decompensation, you can see that systemic inflammation is still present in patients with the responsive ascites, is still present in patients with the grade 1 ascites that I remind you is ascites that can be detected only by abdomen ultrasonography. So systemic inflammation starts very early in the course of the liver disease. Let me go on. This is the module of albumin. You all know that albumin has a residue of cysteine in position 34, which is capable to bind ROS. In doing so, albumin is oxidized. So oxidized albumin is a measure of oxidative stress. And you can see that both non-mercaptoalbumin 1 and non-mercaptoalbumin 2, that are the two forms of oxidized albumin, are increased along the course of the liver disease. So there is another factor that is systemic oxidative stress to be considered in the pathophysiology of decompensation. And so we summarize all these new insights in the pathophysiology of decompensation and organ failure in a new hypothesis on the pathophysiology of decompensation in cirrhosis. The main consequence of portal hypertension and liver failure is bacteria translocation. That is the cause of systemic inflammation and oxidative stress. That is the only cause of the cardiovascular dysfunction in this patient, the only cause of effective hypovolemia. And the effective hypovolemia, together with systemic inflammation and oxidative stress, is responsible for the development of ascites on one side. But you know, systemic inflammation and oxidative stress generates a vicious cycle. The higher level of inflammation and oxidative stress, the higher level of portal hypertension, the higher level of bacteria translocation. So at any time along the course of the liver disease, but particularly in patients with decompensated cirrhosis, organ failure may develop with or without the intervention of precipitating factors. Let me move now to clinics and speak about news in the development, in the management of ascites in patients with cirrhosis. Well, I will speak briefly about the clinical course of grade 1 ascites. I will speak about the long-term use of albumin in the management of responsive ascites and the long-term use of albumin in the management of refractory ascites. Let me move from the beginning. For more than 40 years, we stated that grade 1 ascites should not be treated. I remember that grade 1 ascites is ascites that can be detected only by ultrasonography. But we had no evidence about this. Now we can say that it is correct not to treat this patient because they have not an increased risk to develop overt ascites as compared to patients without ascites. But patients with grade 1 ascites have a reduced probability of survival, as you can see in the midterm, as compared to patients without ascites. Why? Because they have a higher probability to develop acute on chronic liver failure. So it is correct to state that they should not receive dietary sodium restriction, they should not receive diuretics, but they should be followed very closely, more closely than those without ascites. What about the long-term use of albumin in the treatment of responsive ascites? You know that the standard treatment of responsive ascites is dietary sodium restriction and diuretics. Well, in this controlled clinical trial, we compare the standard medical treatment with the standard medical treatment plus the long-term infusion of human albumin solution, 40 grams per week for a period of 18 months. And we were able to show that the use of albumin is capable to reduce the rate of refractory ascites, is capable to reduce of infection other than SBP, hyponatremia, renal impairment, and hepatic encephalopathy. And at the end, the long-term use of albumin solution is capable to improve survival in the patient. What about the long-term use of albumin in patients with refractory ascites? This is the trial we performed. This is not a randomized controlled clinical trial. It is a trial, a prospective trial in real world. And what we did is to compare the standard care, that in this case is a large volume paracentesis plus diuretics, versus the standard of care plus the use of albumin, 40 grams every week. And you can see again that in this type of patient, we were able to show a reduction of 2-year mortality, a reduction of the rate of hospital readmission for any type of complication of the liver disease, with the exception of variceal bleeding. So we think that in both these conditions, responsive ascites and refractory ascites, albumin is active not only through the oncotic property of the molecule, but mainly through the non-oncotic properties of the molecule, particularly exerting an anti-inflammatory act. You can see that albumin is capable to reduce the plasma level of almost all pro-inflammatory cytokines in patients with cirrhosis. And this is enough to recover, for example, the impairment cardiac contractility in this patient. This is an animal model. You can see that albumin is capable to recover cardiac contractility, and this is not the case of any other plasma expander. But this is true now also in patients with cirrhosis. Long-term use of albumin is capable to improve cardiac index. But to get this result, we should give enough amount of albumin, a high dose of albumin. Which is the dose? What I can say now is that if we want to get a significant, stable reduction of the systemic inflammation, we should give 1.5 gram of albumin per kilo of body weight every week. That means in clinical practice, almost to normalize the serum concentration of albumin in your patients. So let me summarize what I said on ascites. I said that patients with grade 1 ascites do not require either dietary sodium restriction or diuretics, but should be followed closely. I said that long-term albumin infusion is effective in the management of both responsive and refractory ascites, but we should give high doses of albumin to get this result. Let me go now to the news in the management of acute kidney injury in patients with cirrhosis. You know, when we set the criteria definition of acute kidney injury, we propose an algorithm for the management of AKI in patients with cirrhosis based on the initial stage of AKI. So you have a patient with initial stage 1 on your left and patient with initial stage higher than 1 on your right. The first group of patients should be treated immediately by very simple measure that you all know. In case of response, everything is fine. In case of no response, without progression of AKI stage, any further decision should be taken case by case. In case of no response with the AKI stage progression, the patient moves to the right side of the algorithm and should receive the treatment that patients were already there had received from the early beginning, that is plasma volume expansion with high doses of albumin for 2 consecutive days. In case of response, everything is fine. In case of no response, the patient should be checked for all the other diagnostic criteria of hepatorenal syndrome. If the patient fulfills the criteria, it should be treated immediately with vasoconstrictor plus albumin in spite of the final value serum creatinine. If the patient does not fulfill the criteria, it can be treated when indicated by other measures. So let me focus now on the diagnosis of HRS-AKI, because our problem is to differentiate among the 4 phenotypes of AKI in this patient. So ATN-AKI, pre-renal AKI, HRS-AKI, and post-renal AKI. So let me say that most cases, pre-renal AKI is solved by plasma volume expansion with albumin. Let me say that post-renal AKI is rare and easy to be diagnosed. So the real problem is to differentiate in between ATN-AKI and HRS-AKI. And what we have our old criteria for the diagnosis of HRS, from which we have only deleted the final value serum creatinine. So nowadays we continue to diagnose this HRS in a patient because it does not respond to withdrawal of diuretics and plasma volume expansion. He has no shock. He's not taking nephrotoxic drug. He has not significant proteinuria, no hematuria, and he has a normal renal ultrasonography. The question is, are these criteria adequate to rule out the presence of structural damage of the kidney, and particularly of tubular damage? If we look to a platform of new biomarkers damage, you can see that abnormal values are present, of course, in patients with ATN-AKI, but also in patients with HRS-AKI as compared to pre-renal AKI and as compared to patients without AKI. So there is some evidence of structural damage, of tubular damage in patients with HRS-AKI diagnosis on our old criteria. And so there are several questions. The first, can we use these new biomarkers to facilitate the differential diagnosis in between ATN-AKI and HRS-AKI? Yes, probably yes, particularly if we use a urinary angle. Urinary angle is capable to facilitate the differential diagnosis in between these 2 conditions because there is no overlap, no substantial overlap in the values comparing patient with HRS-AKI and patient with ATN-AKI. The second and third question are the following. Why there is tubular damage in patient with HRS-AKI, and which is its impact on our treatment? You know, our most common treatment is the use of terlipressin plus albumin. Well, these are the answers. The first, why there is tubular damage in patients with HRS-AKI is the following. Nowadays, we think that the pathophysiology of HRS-AKI is not only renal hypoperfusion. It is a microvascular dysfunction. It is also direct tubular damage and overall inflammation. So the second answer, which is the impact of the tubular damage on the response to our pharmacological treatment? The first is that the more severe degree of inflammation, that means the more severe grade of a CLF, the less response to terlipressin plus albumin for the same value of the baseline serum creatinine. So the more severe inflammation, probably the more severe tubular damage, the less response to the pharmacological treatment. And if we consider an alternative to terlipressin, that is noradrenaline, you can see that in patients who develop HRS-AKI context of ACLF, noradrenaline is quite less effective than terlipressin, both in terms of reversal of renal failure and overall in terms of one survival. Why? Because terlipressin is capable to exert a modest anti-inflammatory action, and this is not true for noradrenaline. So let me summarize this part of AKI is quite frequent in patients with cirrhosis. The KDIGO criteria should be used to make the diagnosis of AKI. A new algorithm should be applied for its management. It is not easy to differentiate in between HRS-AKI and ATN-AKI, but new markers can help us in this difficult differential diagnosis. And finally, terlipressin plus albumin is the best pharmacological treatment of AKI in patients with cirrhosis, particularly in the context of acute on chronic liver failure. Thank you very much for your attention.
Thank you very much, Paolo. This is really an excellent and comprehensive talk. And congratulations to your work, especially the use of albumin to improve the prognosis and management of patients with cirrhosis. Is there any burning questions from the floor? Maybe I might want to ask with the high dose albumin of 1.5 grams per kilogram, so apparently it's a preferred management. Do you still give diuretics for those patients? And if so, which diuretics would you prefer?
You know, in patients with responsive ascites, the answer is yes, and we use the guidelines. So we use the combined treatment, an anti-aldosteronic drug plus furosemide. For patients with refractory ascites, it will depend if the diuretics are effective or not. If they are able to delay the time from one large volume paracentesis and the subsequent, we went on with diuretics. Otherwise, we stopped them.
Thank you very much. Because of the limitations of time, so I would like to pass to our next moderators for the next talk.
Thank you very much. Bye-bye.
Thank you.
Hello. Hello.
Hello.
Hello, Professor Xiao. Hi.
Good morning.
I would like to briefly introduce the next speaker, Professor Ruiping Xiao. She is the winner of the National Science Foundation of Distinguished Young Scholars. She is a tenured professor at Peking University. He is also the current director of the Institute of Molecular Medicine at Peking University. Professor Xiao was trained as a physician scientist in both China and the United States. She received her MD and medical training at Tongji Medical University. She also completed her PhD study in the medical school of the University of Maryland. She spent 20 years in NIH. In 2005, she was invited by Peking University to serve as founding director of the Institute of Molecular Medicine at Peking University. Professor Shaw has played a leading role in clinical translational research on cardiovascular and metabolic disease, and has published more than 100 articles in famous academic journals. And these articles have been cited more than 10,000 times. Since 2000, she has been a member of the Mid-Atlantic Steer Committee of the American Heart Association. Since 2002, Professor Shaw has been a member of the International Heart Society. In 2004, Professor Shaw was selected to the American Society for Clinical Investigation. She has served as an associate editor or editorial board member of many international journals, including the associate editor of the New England Journal of Medicine. So now let's warmly welcome Professor Shaw give us her lecture, the new EGM and clinical research. Let's welcome.
Thank you very much, Dr. Qi. Good morning, ladies and gentlemen. It's my great honor to be invited to talk about the New England Journal of Medicine and Clinical Research. As you know, the journal is the oldest medical journal founded by these two gentlemen, Dr. John Colin Warren and James Jackson. Particularly, Dr. Warren was the first dean of the medical school of Harvard University. He was also the founding member of MGH. Here I list the top 5 global medical journals, including our journal and Lancet, BMJ, JAMA, and the Annual of Internal Medicine. They are all very long history, high-profile journals. The NEJM was founded in 1812. As the oldest medical journal, NEJM has witnessed the history of modern medicine over the past 2 centuries. It has always been at the forefront of medical research and clinical practice, providing readers with timely and objective clinical medical information. Here, I'd like to show you a few milestones. First, for imaging, for example, X-ray films that make the whole diagnosis a big difference. As you can imagine, without that, many of the disease cannot be diagnosed. Here is the first use of X-ray for disease diagnosis, published in our journal in 1896. 6 years after his invention, Dr. Röntgen won the Nobel Prize in Physics. So what's the mission of our journal? Most importantly, is to find the best work and report it dispassionately. Sounds easy, but it's really tough. How to be dispassionate, that's really require very professional team and high standard. Medical journals focus on 3 general areas. First, clinical research. For example, during the COVID-19 pandemics, we have a whole series of publications focused on the clinical characterization of the disease, also the development of novel therapies. We also have many important topics reviewed. The review articles provide a comprehensive picture of the progress for each field, and other articles related to public health and health policies. For some novel therapies, our journal also have a very good vision. The first wave of cancer immunotherapy actually initiated by this couple of publications in our journal about 10 years ago. We also closely watch breakthrough therapies and inform the general public, the medical community. For example, the application of AI in research and clinical practice. We think this can be a very leading field and a very strong implications in our life. Let me talk about briefly how to design clinical research, which is different from basic research. The methodology is different, and the standards also very much different. We have one of the methods is RCT, randomized controlled trial. I will talk a little bit in detail about this. Why is that? There are many different ways to do clinical research, but the levels of evidence is different. In this kind of order, first, the strongest one is randomized clinical trial, followed by prospective cohort study, retrospective cohort study, case control study, and case series. RCT can provide the strongest evidence of cause and effect. Why is that? Because there are three important ways to control the errors and the artificials. First, randomization. This can normalize the baseline, the distribute baseline characteristic, can make the control group very comparable to the therapy group. Then we also emphasize control group to address the placebo effects. And the blinding is also extremely important. Ideally, subjects and the investigators should be double blind to reduce bias, to prevent differential compliance and treatment. I'll give you a simple example. Actually, now it become a classic example. It's the SPRING study. We all know the treatment of hypertension. When I was a medical student, we think about 140 and 90 should be the standard. But now this trial try to compare intensive treatment with the standard treatment. So the first table published in the journal is the two groups of the patients, intensive treatment and standard treatment. We can see from here, they are very comparable baselines. So in the journal, we don't need a statistic for the table 1. You just list the mean for these different arms, different groups. Here is the data for a 5-year follow-up study. As the standard therapy and the intensive therapy, you can tell very well controlled systolic blood pressure in both groups. The standard treatment is below 140, and intensive treatment is below 130. What's the outcome? As shown in here, primary outcome include myocardial infarction, acute coronary syndrome, and stroke, congestive heart failure, cardiovascular death. Clearly, intensive treatment is much more beneficial. The same is true for another outcome, death of any cause. You can tell from this result, intensive therapy is also better than the standard therapy. So what is the right systolic blood pressure? In our textbook for many, many years was 140 and 90. After the spring study, AHA and the CIA changed the guideline to 130 and 80. That was the first change for hypertension definition in 14 years. So the study really changed practice. After you submit the paper to our journal, what's the critical points the reviewers and editors look at? First, we have to see the question, whether it's an important question. Is it going to change the clinical practice or not? Then we will put attention on your design and the execution of the trial, the quality of the study, to see the internal vitality and external vitality for all those, whether the study can be generalized. And the reporting of the trial, the writing, the presentation of the figure, and also whether the logic is clear. So after you submit your manuscript to the journal, our editor-in-chief, Dr. Eric Rubin, will screen all of the submissions. A quarter of the manuscripts will be immediately rejected. Then others will go to associate editors or deputy editors for peer review, in-depth review. After the comments come back, we have editorial meetings twice a week, very intensive, very careful review process during the meeting. So in 2018, we have more than 16,000 submissions, about a quarter original research articles. Also, interestingly, there are many, like a case report for imagings and letters. So the decisions on the research submission, about 2/3 were rejected immediately. That was very quick, usually within a couple of weeks, you will know the decision. Only very small fraction of the paper can make it. About 0.4% we will say we're highly interested, it's very important. Then you could just without revision or very minor revision. About the other 4.5% need intensive imaging. So after you go through all the steps, we have the initial decision, but our in-house statistic team will do a careful job for the statistic review. Again, about 20% of the papers will be failed at this step due to the methodology or the power is not enough or other reasons. So in 2018, we have 242 research articles. These are the most important part. We also have more than 700 letters. Some of the letters are also very informative. They are original data or table or figures. So some of the just like short papers of the original articles. How about the situation in China? As you know, the disease burden in China is overwhelming. Here I use cancer as an example. More than half of the liver cancers, the percentage of the global deaths was in China. And actually the situation is continuous still in China. For gastric cancer, it's a similar situation. Lung cancer also #1 in China. Even for the same kind of disease, the mortality in China is higher than in Western countries. Here, at least stroke and COPD, as you can see, compared to Western countries, the mortality in China is much higher. So it is very important and timing to build a bridge connecting China with the rest of the world. First with the journal. This dream was come true in 2014. By the time, Dr. Ng Wang was the president of Peking University, had a shake hand with our editor-in-chief, Dr. Dreesen, was a former editor-in-chief. He traveled to Beijing, opened the office, the NEJM China office. Now it's located in the building WangKezhen Lou. Meanwhile, Dr. Gary Wang and myself were appointed as associate editors for the journal to represent China and Asia Pacific. 2 years later, we launched the Chinese platform of the journal, Chinese version, NEJM 医学前沿. Dr. Dreesen made another trip to Shanghai, made the announcement. And our sponsor, Mr. Feng Ge, the president of Jiahui International Hospital in Shanghai, he supported a lot for this platform. Chinese government also invested a lot, built up a lot of clinical research centers. For example, for stroke research, there are more than 140 clinical centers. Other initiatives, for example, the R&D initiative for drug development and precision medicine. In this platform, we try to train professionals with different interface. We have WeChat, we have mobile phone with PC and app. We also have online and offline training. With all those joint efforts, we can see China is catching up rapidly for clinical research and clinical practice. For original articles, China-based research articles, you can see increase rapidly. Particularly during the COVID-19 pandemic, a lot of milestone articles published in our journal are produced from China. So I highlight here the 2 original articles from CTC China. These are very important data shared in the early days. So the international community can have the sequence, also know human-to-human transmission. In March, at the end of February, Dr. Nan Sansong's group published a big scale study for COVID-19 patients, characterized all the clinical features. In March, Dr. Bin Chao and Chen Wang published a clinical trial. Although the outcome was selective, but the study was very well conducted, well designed. In addition, there are multiple aspects, different group of subpopulation with different background disease, all published together. We have 9 articles published in our journal. It's based by authors based in China. For another educational program is for the training of key opinion leaders. They are the leaders in the hospitals, in medical schools, in our medical communities. So in 2017, 18, and 19, we took them to Boston, invite them for the editorial board meeting, and also for other kind of activities. This is very highly appreciated by our KOLs. So let's join the efforts for better medical journals, for better medical research, eventually for better life. Thank you very much.
Hello.
Hey.
Thanks, Professor Shaw, for giving us the very important lecture, especially the peer review per case of the new EGM journal. I think it will be benefit both for the clinical physicians as well as for the editors, especially the medical journal publication, the staffs. As the schedule is very tight, and let's move to the next session. Thank you.
Thank you, Dr. Wang.
Thank you.
我这个要退出来。
Hello, good morning, everybody. And then because of no time for break, so we should move on. Where the next speaker is Professor George Law. He's the chairman and a senior consultant in gastroenterology and hepatology, humanity and health medical group. As we know, Professor George Law is a well-known professor in the field of hepatology. He's also the chair professor in clinical hepatology. And also, importantly, he is the steering committee member of APASL. He's also the past APASL president. And he has published a lot of prestigious articles in prestigious journals, where Professor George Law is ready. And then we welcome Professor George Law give us a talk. His title is the diagnosis and management of varicose bleeding. Welcome, Professor George Law.
Thank you, Fu Seng, and dear colleagues, and congratulations to the Professor Qi Xiaolong in organizing this single topic conference on a very important topic in hepatology. And on behalf of the APASL steering committee, I want to say thank you for the organizing committee. The title assigned to me today for the talk is Diagnosis and Management of Varicose Bleeding. Well, this is a very important topic. Being a practicing gastroenterologist and hepatologist, in Hong Kong and also Beijing. I work with Fusen for more than 15 years now. And thanks for the One Country and Two Systems, which allowed us to collaborate more. We see a lot of patients who come in with variceal bleeding. Though in the past 10, 15 years, I have to say that the incidence and the cases we've seen is dropping dramatically. But still, it is a very important topic. And in the next 15 minutes, I would like to share with you some of our present understandings of the management of variceal bleeding related mainly to patients with liver cirrhosis, especially those who are decompensated. The areas I'm going to cover with you today is how we should prevent the first variceal hemorrhage. And this is very important because if we can prevent it, we can drastically improve the outcomes of those patients with these complications in those with end-stage cirrhosis. And how are we going to treat with acute variceal hemorrhage and how to prevent rebleeding? Well, as alluded by the Professor S.K. Sarain in the earlier excellent talk, the outcomes of variceal bleedings is mainly related to hepatic venous pressure gradients, and that is portal hypertension. As you can see here in this landmark papers published in 2008, it's a hepatic venous pressure gradients is directly related to the 5 days failures of variceal bleeding controls and also the mortality and morbidities related to acute variceal bleeding. And therefore, the portal pressures of greater or equals to 20 millimeter of mercury is of paramount importance. It is therefore a need for us to reduce the portal hypertension in these patients to reduce the risk out of variceal hemorrhage and its mortality and morbidity. Well, up to now, the detections of esophageal gastric varices relies heavily on the performance of upper endoscopies, which is still considered as a gold standard for the diagnosis and the management and assessments of esophageal gastric varices. And it is a need for us to identify those who has not bled, but with a high risk of bleedings and to deal with it prophylactically to prevent bleedings in those patients. Because once they bled, they carry a high risk of mortality and morbidity. These high risk factors, as visualized in the endoscopies, include red well marks, large varices greater than 5 millimeters, or the giant varices. Well, recently the capsule endoscopy has also been introduced, but it is cumbersome and personally in our centers, it is not a very usual practice to use capsule endoscopies to diagnose those varices which has not bled. On the other hand, because of the use of upper endoscopies still carries a certain type of risk, non-invasive tests has recently been advocated. These non-invasive tests is meant to detect and to exclude those patients who will not benefit from upper endoscopies for the diagnosis and assessments of varices. And we can safely exclude them from endoscopy and sedations. It is cost effective and it lowers the patient's and insurance cost, and it is more accessible.
Please share your screen with us. We cannot see your slides.
You cannot see the screen.
Yeah, share your screen. 共享你的屏幕.
Okay.
Yes.
Can you see?
Yes,
no?
Exactly.
Is now okay? Yes, okay.
Yes.
Thank you very much because I do not know the real times over there. And another factor is accessible, and it has to be made more readily available than endoscopy and improve adherence to screening. It is also effective in a sense that it can identify patients of high risk varices with a low missing rate. Now, one of the examples, Fusen, can you see the screen? Fusen, can you see the screen?
Yes.
Yes, thank you very much for verifying with me. Well, one of the examples of this risk score is, I would like to illustrate, is the male-based models to determine the risk of mortality among patients with acute variceal bleeding, and performed by the Spanish group. As you can see here, using a male modified scores of values of greater than 19, there is a predictions of 20% of greater mortality. So whereas a male scores of less than 11 predicted less than 5% mortality. So the area under the curve is excellent to predict the 6 weeks of mortality in acute variceal bleeding. So that with the use of these prognostic models with the risk scores, we are pretty safe to exclude or to prevent the use of endoscopies in up to 43%. Say, for instance, with the use of Baveno 6 criteria or expanded Baveno 6 criteria, with the cutoffs of the liver stiffness of less than 20 kilopascals and platelet counts of more than 1,500,000, or in a more expanded Baveno's criteria of a liver stiffness of less than 25 kilopascals and a platelet counts of greater than 1,100,000. So we can help in those patients using these scores and to avoid them to undergo the endoscopies, but still we are confident enough that they will not suffer from the variceal bleeding without doing an endoscopy and the prophylactic variceal treatment. Well, recently, in attempts to further improve the use of these risk scores, spleen stiffness measurements has also been incorporated, as shown in this studies published recently in the Journal of Hepatology, where the SSM, that is the spleen stiffness measurements, was incorporated with a values cut off of 46 kilopascals to improve the use of Baveno 6 criteria. And with the use of these combined scores, so we are more confident in excluding the patients of the necessities of undergoing the endoscopic assessments of the presence of high-risk varices in patients with advanced chronic liver diseases. The validations of the Baveno 6 criteria for screening and surveillance of esophageal varices has also been validated in patients with compensated cirrhosis and who has been treated successfully. Because in the recent few years, we are now in a very good position to eradicate the viral factors causing the end-stage liver cirrhosis, such as chronic hepatitis C. So we have pan-oral direct-acting antiviral agents for the complete remission or sustained virological remissions. And for chronic patients with chronic hepatitis B, we have potent nucleoside or nucleotide analogs to completely suppress the viral replications and normalize and regressions of the fibrosis could also happen. So it is of great importance to really see how this Baveno 6 status will change with the SVR, that is sustained virological response in those patients. And it is shown here in this paper published last year in the gastroenterology that the Baveno 6 status after SVR was associated with the lack of portal hypertension progressions, defined as the onset of varices needing treatments and its related bleedings. Therefore, it is pretty safe to use these risk scores in those patients who has undergone eradications of the underlying cause of the liver cirrhosis and is still of great value. Non-invasive predictions of esophageal varices by liver stiffness measurements and platelets validations in other diseases such as fatty livers, and in this case, this paper, it was in the non-alcoholic fatty liver disease, has also been validated based on the liver stiffness measurements and the platelet count. So we are pretty confident to avoid doing the unnecessary endoscopies for assessments in those patients with liver cirrhosis. And this paper was published by our chairperson, Professor Xiaolong Qi, recently, which validates the use of Baveno 6 and expanded the Baveno 6 criteria in the high-risk varices patients, with those patients with MAFA, which is a newly redefined definitions of fatty livers, metabolic associated fatty liver diseases and compensated cirrhosis. It is clearly shows that both criteria is still of great use in these patients to help us to decide who will need the endoscopies and who will not need an endoscopy. This table summarizes the use of these risk scores in those patients with fatty livers, cholestatic liver diseases, and viral hepatitis with viral suppressions, both in hepatitis B and hepatitis C, which is of great values and could help us to avoid the use of endoscopies in those patients with chronic liver disease, especially those with decompensated liver cirrhosis, to have to undergo the endoscopic assessments to detect high risk varices for the proactive variceal control, up to 40% of the cases. Well, this algorithms was recently published in the Clinical Liver Diseases by the Professor Kim, and I would like to share with you that I think this is a very reasonable flowchart to how we should manage the patients with newly diagnosed cirrhosis. If it is compensated and with mild hypertension and clinical significant portal hypertension, we can do non-invasive tests such as the Baveno 6 or modified Baveno 6. And if data meets the criteria to rule out high risk factors, we are pretty safe to avoid endoscopy. However, if it does not meet the criteria or it's indicated to have high risk varices, then together with those patients who has decompensated cirrhosis, we will need an upper endoscopy. Using this algorithm, we can avoid up to 40% of endoscopies to be performed in those patients with liver cirrhosis, especially those with compensated liver cirrhosis. Now, with the detections or with the suspicions of high-risk varices and validated by the endoscopy findings, we need to prevent it from further bleedings. As elucidated in the previous slides, these are the patients with red stigmatas or the big or the large size varices. We will do the esophageal variceal ligations until the varices is eradicated, together with the applications of beta blockers to lower the portal hypertension. Now, this flowchart is a summary of how we would manage the acute variceal bleeding at our centers. The main therapeutic outcomes matrix were to control active bleedings, preventions of rebleedings, and reductions of early mortality. We will first stabilize the patients hemodynamically and consider elective intubations. IV antibiotics will be given, and vasoactive medications such as octreotide will be given, or the tirapressins. This has all been shown by the randomized control studies and also using of meta-analysis to be of value, to lower the portal pressures and to improve the outcomes. Upper endoscopies would then be performed as soon as possible, usually within 12 hours, to the controls the variceal bleedings and with bending ligations or the sclerotherapy. Now, one of the problems with variceal bleeding is the rebleedings after the initial control. And it is very important that we carefully eradicate the varices with repeated endoscopies. In our centers, we usually perform endoscopies every 4 to 6 weeks until there is eradication of the varices with bending or sclerotherapy, together with the use of beta blockers. In our centers, we use nadolol more, but in the old days, we use propranolol. And the target with a targeting heart rate of 55 to the 60s. And the systolic blood pressure should not decrease to less than 19 millimeter mercury. Now, how about the use of tips? Well, it is cumbersome, and sometimes in the practicalities, it is difficult to convince the patients, and some of our surgeons still is very reluctant to use tips. But the early use of tips in the patients with cirrhosis and variceal bleeding has been proven to of benefit. And these papers were published in the New England Journal of Medicine some 10 years ago, which shows that patients with Childbirth class C, that is a score of 10 to 13, or the class B, a score of 7 to 9 with active bleedings, will benefit in terms of survivals and controlling of the bleedings with the use of tips. Use of early tips also in these cases does not increase as what we use to worry about, and that is hepatic encephalopathy. So I think that these patients could benefit from tips and should be considered, and some of our colleagues with the old thinking that it might aggravate the liver failures and hepatic encephalopathy, that should be reassured. Last but not least, I would like to touch upon how we manage the gastric varices. And this credit goes to our chairmen of the steering committees of APASL, Professor S.K. Serene, and I think that this is the standards and international standards we are adopting of how we classify the gastric varices. Those with the type 1s that along the lesser curve, and so we use variceal ligations. Apart from those with those varices in the fundus or isolated gastric varices in the fundus or the first part of the duodenums or other part of the stomach, we use cyanode acrylated crude management. And this is the standard of care we adopt here in Hong Kong and also in most parts of the world. This is the algorithms adopted by adopted and recommended by APASL, the portal hypertension consensus meetings, and the papers were published 9 years ago with the corresponding office of Professor S.K. Saring himself. This shows that those patients with bleeding gastric varices after resuscitations, and if they have the GOV2 or the IgV1 or IgV2, we use the tissue adhesive. And for those with a GOV1 that is along the lesser curve, we use bending ligations or the tissues adhesive. After the control of bleeding, we should consider secondary prophylaxis. If the control of bleeding is not successful, then we proceed to the balloon tamponade. And also, these patients should be actively considered for salvage tips, shunt surgeries, or the liver transplantations, and sometimes splenectomies for embolizations in segmental portal hypertension. So in summary, Professor Fusen Wang, ladies and gentlemen, and risk assessments and preventions of first hemorrhage is of paramount importance, though, as I have mentioned, variceal bleeding becomes less and less frequent because of the wide use of effective antiviral agents in terms of the treatments of hepatitis C and hepatitis B. But for those patients who had the high risk of variceal bleeding, and identified initially by the high-risk scores and then confirmed by endoscopies with the signs of high-risk bleedings, esophageal band ligations together with the use of non-selective beta blockers is advocated. For those who are already bleeding, the volume resuscitations, the use of vasoactive medications such as octreotide, prophylactic antibiotics, and endoscopic hemostasis is a must. In order to prevent further bleedings, further band ligations and eradications of the varices together with the help of non-selective beta blockers to lower the portal pressures is necessary. For those patients who have gastric variceal hemorrhage, the use of tissue glue, sclerotherapies, or band ligations is the recommended management. Last but not least, I would like to thank my collaborators in humanity and health medical groups. So I now work with our ex-dean of the Faculty of Medicine, University of Hong Kong, Professor S.K. Lam, who brought me into China, and he is the first ones to introduce the use of endoscopy in China. And I also work with liver cirrhosis and diagnosis groups in Beijing as a co-director of the liver diseases and transplant centers and in 302 hospitals, where Professor Fusen Wang is my close collaborator in many of the studies, and I learned a lot from the good people in the 302, and now it's called the 5th Medical Center in China. But I would like also to take these opportunities to congratulate some of our friends who was recently awarded the Nobel Prize of Medicine for the discoveries of hepatitis C. This is of great importance in relevance to portal hypertension and variceal bleedings, because with the eradications of hepatitis C and the controls of the viral replications, and so we will see less and less portal hypertension and also less and less variceal bleedings. And even for those with variceal bleedings, the controls of the virus will help also to reduce the portal hypertension and to improve the outcomes of variceal bleeding. This is the slides I prepared for the students and the newcomers to our fields in hepatology. Having been in the fields for 30 years, I really want to see new, young, energetic people to carry on our work, especially in my beloved country, China. Well, to have good publications is important, but it is also important to have the heart. And I would like to illustrate this with Professor Dr. Harvey Alters and NIH, who was the awardees of the recent Nobel Prize. As you can see here, when he was 30 years old, he published the papers with Plumberg, new antigens in leukemia sera, that is hepatitis B, with very high citations. And the second paper is at the age of 37 years old, post-transfusion hepatitis after exclusions of commercials and hepatitis B antigen positive donors in Annals of Internal Medicine. And at the age of 54 years old, the detection of hepatitis C in the transfusion recipients with acute and chronic and non-A, non-B hepatitis in New England Journal of Medicine. This is the slides I borrowed from Harvey's yesterday after I congratulate him in person. And he is a very humble person, willing to interact with each other. And I hope that our research communities in hepatology, especially in China, where liver diseases is very, very prominent, will follow his track. Very humble, and you can see the path from the age of 20 to the age of 80s. But he goes one step forward. He got the Nobel Prize. Thank you very much.
Thank you very much, Professor George Lau, for your wonderful talk. Thank you very much for your give us comprehensive analysis and summary in diagnosis and management of varicose bleeding. In addition, especially in particular, you just summarized the 3 Nobel laureates this year who have been working in chronic hepatitis C. It's a wonderful job. Due to because we are lag behind more than 20 minutes, so we have no questions. Anyway, we thank you very much again for your wonderful talk.
Thank you, Professor Wang.
We should move on. Thank you. We are waiting for next chairperson, Professor Wei Lai.
So, good morning. And it's my great honor to introduce the next speaker. Next speaker is Professor Masa Omata. Masa Omata, Professor Omata, everybody, you know him. And he's the co-editor-in-chief of the Hepatology International. And actually, Professor Omata, he made a great effort to revitalize the APASL and with Dr. Sarin and others in 1 decade recently. And he changed the APASL, the history, and also make a big impact. And currently, Professor Omata is still very active. And he's the president of the Yamanashi Center and the Kito and the hospital, and the 2 hospital president. And also he still is a professor emeritus and of the University of Tokyo. And in addition to the clinical and the work and the practice and the research, and the Professor Omata, and also made and agreed in the contribution to the molecular biology study of the virus, and published a lot of the papers in New England Journal of Medicine, Lancet, and others. So, today, Professor Omata will give us a talk on the SVR-related HCC and the genomics. So, please welcome Professor Omata. Please, Professor Omata.
Yes, thanks a lot, Wei Lai. How are you? Wonderful talk, George Lau. After George Lau, I may touch upon the hepatocellular carcinoma, and especially in our country, Hep C is the biggest problem. Therefore, I may have to talk about the matter of the SVRs and how to follow the patients. And in fact, today's my topic title is genomics in SVR patients. And thanks to the Dr. Shinaji, in fact, he created wonderful drug, chain terminators. Then that's based upon the Nobel Prizes, just George Lau mentioned. This is one of the meetings in HepDAT. Actually, HepDAT created a lot of discussion about how to make better drugs. This is a meeting in 2011. And we had a long interferon era for 20 years. But now we can expect 100% cure by DAA, antiviral drugs. And Japanese situation is a bit different from the Chinese because at most 80% is due to the severe infections. And elimination, WHO saying 2030 is a target, but in reality, we started the treatment 2013, and in 2015, the biggest treatment numbers attained. So 2020, we are expecting two things, Olympic Games and this eradication of the SCV in our country 10 years earlier. Actually, in my clinic, we currently see only a few who come as newcomers for the treatment. But what is left? Well, there is some dispute. There are several disputes on the occurrence of hepatocellular carcinoma. Of course, not just hep C, but hep B or NASH or MASH. But if you take the instance of the hepatocellular carcinoma of the patients who completed the treatment and then got the SVR, whether they still continue to have the cancer or not, there are two reports, earlier reports. One group said 28 to 29%. The other group said 0% or maybe 3%. What are the discrepancies? Based upon, we have to make guidelines. It was a very difficult situations. Actually, we initiated two independent cohort studies, and occurrence we calculated. In cohort C, it was 6.5%, and the other 2.7%. So altogether, about 5%, or a little less than 5%. But this is only 1 to 2 years of follow-up. But in that cases, we occurrence correlated to the history of the hepatocellular carcinoma, whether they had the treatment previously or not. And if there is no previous history of the hepatocellular carcinoma in two cohorts, it varied from 1 to 3%. But if you take the patients who are diagnosed of having hepatocellular carcinoma and treated nicely and no remnants, the occurrence was very high and 22 to 26.5%. Actually, in that time, we searched the literatures, and there were 18 studies, and the SVR rates, the occurrence rate after SVR was 1.8%. But again, we divide them into two groups. Without previous history of hepatocellular carcinoma, it was 1.3%. But with history of hepatocellular carcinoma, there was 6 studies, and of 602, it was 29.6%. So the literature indicates there must be some reason, and there is a difference. Many people think maybe it's because our treatment for hepatocellular carcinoma by itself might be something wrong. But also we are carefully checking those patients and then confirming that there is no more cancer left before we started the treatment, especially in my clinic. But we made temporary guidelines. If and then when the SVR are attained, and then there is a history of hepatocellular carcinoma, then follow-up should be a bit careful every 4 months. And then we got to check by ultrasound and tumor markers. But if there is no history of the previous hepatocellular carcinoma, maybe we can divide into two groups. One is advanced fibrosis and one without fibrosis. If there is fibrosis and no history of hepatocellular carcinoma, maybe we can check every 6 months by ultrasound and tumor markers. But there is no history, no fibrosis. Maybe every 6 months is for 2 years. And then after 2 years, maybe every 12 months. But the last part, we assumed because our follow-up study and then most of the literature is follow-up period is only a matter of 1 to 2 years. Therefore, I expanded and extended, updated this Y cohort and follow-up period extended to 4 years. Actually, in my clinic, even though the virus eradicated, somehow patients might come. Therefore, I had a chance to check them. There was a 612 SVR patients and the virus eradicated in between 2013 and 2020. And average follow-up, as I said, 4 years, 1 to 7 years. And this is the incidence of hepatocellular carcinoma. They continue to have cancers. And the occurrence rate went up to the 7.8%, comparing to 1 to 2% in previous short-term follow-up period. Then we divided them into, again, with and without previous history of hepatocellular carcinoma. You can see a marked difference. The pink lines indicate those with previous hepatocellular carcinoma history, and others is the one without history of hepatocellular carcinoma. When you take a look at the pink lines, not just very early time, but also in 2-3 years, they are still climbing up. Therefore, maybe we don't need change the guidelines. And then we conducted the molecular analysis. Why they happens or they continue to happen. Then in this particular case, 83-year-old man, he had 2 cancers, T1 and T2. And in between T1 and T2, we gave a DAA. And then we took a tissue, analyzed, and then molecularly diagnosed. As you see here, it seems there is a duration between the 2013 and 2020, 7-year differences. There are no shared variants among 2 different tumor nodules. So they are different, 2 different clones, not a remnant, not a residual cancers. The next one, there are the 3 nodules. One, T1 and T2 is a before DAA, T1 and T2. Then after DAA, T3 showed up and relatively small in size except T1. And then we did the molecular analysis, and this is the heat maps of the analysis. And as I shown here, 2010 November and 2012 May, this is a 2 cancer nodule before the DAAs. They are having the shared variants here. So they are the same clones. But after DAAs, 8 years after, there are another cancer developed, and this one is totally different. So this indicates before the DAA, they are the same clones, but after the DAA, it was the different ones. So this again indicates this is not the remnants of the hepatocellular carcinomas of the previous treatment. This is the third one, 69-year-old man, T1 and T2 here and T3 here. And we did analysis, DAA was given in 2015, 5 years ago. And before the DAA, there is one cancer. And then after TAA, there are synchronous 2 cancer nodules. In other words, T2 and T3 happens at the same time. As you see here, obviously, they are totally different clones, individuals. Again, this is not a remnant. So these things indicate somehow the patient who experienced cancer beforehand, even though the virus cleared, they continue to show the very higher frequency of higher potential of the hepatocellular carcinoma. And this majority of them may be a de novo occurrence with higher frequencies. I only studied 3 cases, but as you know, it's not so easy to collect the data or the material because many of them are not showing the cancers anymore, or maybe I don't know the situation in China, but some doctors say, okay, you are okay, don't worry about the cancer, but then the patient don't show up. But anyhow, this is one aspect I noticed. I started my career in 1970, 50 years ago. And then my first paper is on hepatocellular carcinoma somehow, but not in Japan, but in the United States. Since then, I came back to Japan in 1979, joined with Okuda, and then there was an exponential increase. And then SCB discovery by Michael Houghton, and 2002, it reached a peak. Then DAA, direct antiviral agent came. And 2018, this is a situation of the annual deaths in our countries. But when you sit down in the clinic, keep seeing the patients about there is a clinical matters. Maybe some are more important because even though we are expecting the reduction of hepatocellular carcinoma, but these patients also have the chance to get another malignancies. In fact, in this cohort, 32 patients develop other cancers, such as gastric, colorectal, lung, prostate, OBGYN, and such. So if you compare and include all cancer, it's climbed to 13.1%. This is a side-by-side comparisons. Actually, the shape is similar, except the early time of the STC occurs more frequently in these SVRs. That means we are the hepatologists, we are the infectious people, but we have to watch other malignancy for the sake of patients, whole life. So we then checked prognosis of patients who developed SCC and non-SCC malignancies. And overall survival, it's about 80% in 4 years. That's okay, because they are kept checked and the majority are found early in the stages, but still 4-year survival, 80%. There is no difference between the SCC and non-SCCs. So clinically, as the clinicians, when you keep seeing these patients, we have to expand our areas, not just watching the hepatocellular carcinoma, or also other malignancies. Actually, when you talk about the treatment of the cancers, many of the informations, many of drugs sharing each other from different areas to areas. So when you stick to the oncology, I don't think it's wise to just stick to the hepatocellular carcinoma. So clinically, our APASL guideline still holds. In addition, we have to care about other malignancies. Genetically, we have to understand why that happens so frequently once they developed and cured for the hepatocellular carcinoma. I think there must be something behind, there might be some secrets behind. Well, I really appreciate for Chinese colleagues. because I've been working for 50 years. And in fact, for this single topic, I'm extremely busy now for the corona problems and also other matters in the hospital. So I for the last maybe 3 days, worked almost, I don't know, 20 hours or maybe 18 hours. So I'm sorry, I'm a bit behind maybe, but I think I finished my responsibilities, and I really appreciate Wei Hussein Wang, George Lau, Jidong Zhao, and everybody, Chinese colleagues. Thank you very much. 谢谢.
Thank you, Professor Omata, very extended and comprehensive talk, and the many and the new finding and the discovery. I think maybe in the future we can undertake someone to do the validation in our cohort, both in HCV, HB, and related HCC population. And it's very nice to see you in the online. Unfortunately, we cannot see in the face-to-face and due to the COVID-19. And due to the limited time, and we will not have discussion and Q&A. But the thanks to Professor Omata for very light and very excellent talk, and also the kind of words in 2020 APASL Public Conference for the portal hypertension. So let us and thanks to Professor Omata again.
Thank you.
Thank you, Professor.
All right. I want to see you really. Thank you very much. Yes, bye-bye. Bye-bye. ちょっとね、遅れたんで。あの時さ、なんか慌てるね。ちょっとどうして何がどこが違ったの？画面共有。ちょっと待ってます。
Okay, so this is the first on-site talk, and it's my great honor to introduce the speaker from Beijing, Professor Jia. I don't think we need more introduction for Professor Jia, but we have internet, many audience from internet, so I would like to have a brief introduction of Professor Jia. He's a professor of medicine, director of the Research Center, Beijing Friendship Hospital from the Capital Medical University. Professor Jia is the president of APASL in 2010. So to save the time, I would like to pass the microphone to Professor Jia, please.
Thank you, Professor Sun. Also, thank you, Dr. Qi, to organize this meeting. In the next 15 minutes, I will keep in time. I have my own timer because the time is running out. Today, my topic is about idiopathic non-cirrhotic portal hypertension. Well, I will briefly talk about the etiology, pathophysiology, and clinical manifestation, as well as diagnosis and treatment of this disease. This slide illustrates classification of portal hypertension. Cirrhosis is a protoform and the most common type of portal hypertension, which is sinusoidal. Whereas we have pre-hepatic, pre-sinusoidal, we have post-sinusoidal, post-hepatic portal hypertension. Today, idiopathic non-cirrhotic portal hypertension is at the early stages, is pre-hepatic, is pre-sinusoidal portal hypertension. While historically, there are many names about this disease. Well, it's we can see that it was called hepatoportal sclerosis, non-cirrhotic fibrosis, non-cirrhotic portal hypertension, and also they called obliterative portal venopathy. Perhaps obliterative portal venopathy is more precise, but unfortunately now it's generally called idiopathic non-cirrhotic portal hypertension. So in Japan, it's mainly seen in middle-aged women, whereas in India, it's mainly seen young-aged boys and young men. The etiology is a little bit complex, maybe related to infection, toxin, autoimmune inflammation, and procoagulation. Now, I just show some studies showing the genetic background. This is just some case reports, but just show you some mutation in this so-called KCNN, which is a very long name. This is a kind of autosomal dominant mutation, but they just find in some cases. This need to be further validated in the future studies. Another one is so-called recurrent recessive mutation in the deoxyguanosine kinase. This will also cause idiopathic non-cirrhotic portal hypertension. From this slide, we can see that two cases from two families, but both maybe from the common ancestor. Again, this kind of mutation may be a genetic background for this disease. And finally, I just talk to you about some so-called ADMATS11. This is also a very, very long name. It's a kind of enzyme that try to leverage the von Willebrand, which is a clotting factor, the coagulation factor. The balance between this von Willebrand factor and the ADAMTS13 will change in the disease of this portal hypertension. We can see in general that the von Willebrand is increased in this disease, whereas this factor will decrease. So the ratio will change. This kind of unbalance in coagulation will be subjected, the precipitating factor for this disease. Now, this disease summarizes the possible etiology of this disease in India. We can see again, toxin, arsenicosis, or enteropathy, or hypovitaminoses of vitamin B12. So all these kind of environmental factors. So we have genetic background, as I have 3 examples here. We have environmental factors, toxin, infection, and inflammation. So now this slide is prepared by Professor Sarin. He believed that this kind of disease may be common to the actual hepatic portal vein obligation. The difference is if occurred, the damage, infection, for example, occurred in early stage, in newborn, in early childhood, it may be infected the main brain, the branch of the portal vein. They will manifest as actual hepatic portal vein obligation. Whereas if it is mild, occurred in childhood or young adults, and mainly affected the peripheral branch of portal vein, then it will manifest as idiopathic non-cirrhotic portal hypertension. Due to limited time, I will not go through all this much details, but this is just a kind of series of this disease. So now I would like to talk about the clinical manifestation of disease. This slide is showing there are more than 300 cases reported by China, Japan, Friendship Hospital, not our own hospital. Our hospital is Soviet Union, China Friendship Hospital. This from China, Japan Friendship Hospital. Actually, from Professor Wang Tailin's consultation from pathology, from the over 62 hospitals in China, we can see the main manifestations, enlargement of spleen, hypersplenism, varices, esophageal varices, bleeding, ascites, and also other things. So this is, I think this is the largest series I could see. But in that paper, they use the term idiopathic portal hypertension. Now, this is age distribution. You can see this is very interesting. You can see the male in the black bar in the young age, like in India, whereas for women, in the middle age, so very much like that in Japan. So in China, we can say the features of this disease similar to both that in India and Japan. Now, this is a very old publication, just showing, very nicely showing the port vein system. You can see that's a normal one, there's a normal, that's the cirrhotic in I will use this. I hope you can see. This is a cirrhotic. This is this disease. We can see the sparse and the sudden disappear of the peripheral, just like somehow like the primary sclerosing cholangitis. But this is a port vein. This is not the cholangitis. But like this, we can see the wall of the port vein is thickening, and also we see some kind of changes in the CAT scan. If you are not familiar with disease, it's very easy to be diagnosed as a cirrhosis, but it's not real cirrhosis. For pathological changes, there are many different terms used to describe this disease. So last year, a group of pathologists and clinicians published a consensus like that. They published a proposed nomenclature and a term to describe this disease, and also to describe this the changes of histology. I just tell you there are some distinctive features of this disease. You can see phlebosclerosis. I'm sorry, one S is missing. I don't know why. And also the port vein remnant. That means the port vein disappeared due to the obliterative venopathy. And you can also see some kind of thickening of the port vein. And also you can see the nodal regeneration. So all these are unique features of this disease. Whereas the next slide, this is kind of, I would say that's a secondary feature of the disease. That's due to the portal hypertension. In other side, or near these changes, we have the dilation of the so-called aberrant blood vessels. That's kind of a compensation. Because the port vein obliterated, sclerosed, or disappeared. So the other side, there will be some other blood vessels try to drain the blood. So this is not specific, but this is just a complementary, a secondary to the previous ones. Now, so this slide is better. We can see the kind of thinning of the collagen. That's a very round portal area with a very small thickened portal vein vessels. We can see also even paired. We can also see the incomplete septor. We can see all these kind of features put together give us clue for the diagnosis of this disease. Well, more recently, actually in the early morning, 1 o'clock this morning, I added this slide. This is from published from American, although the first author is a Chinese, obviously, like Liang, but published from American. From this paper, very interesting, they confirm, they emphasize the primary changes, as I mentioned earlier, is really diagnostic, where the secondary portal pressure related changes is not specific. See, what they say like this, if you just have this kind of so-called portal vein sclerosis, they already have the area on the curve nearly 0.9. If you even add the kind of secondary changes, only slightly increase the diagnostic accuracy. So the main idea of this paper is they emphasize the primary changes. Secondary changes just kind of support, not diagnostic. So they recommended that kind of 3 categories of diagnosis. They consistent with disease, indeterminate for this disease, and not consistent with disease. They mainly on the presence of the primary changes, the primary of the secondary changes, or no primary changes of these changes. So I think this is a very important paper for diagnosis. Now, very briefly, that's the natural history of this disease. Again, this paper is published by Professor Sarin. You know, as I mentioned, he's really one of the pioneers in the field of portal hypertension, because in India, this disease is very prevalent. So from early stage, just enlargement of spleen, so-called splenomegaly, then varices, variceal bleeding, Then gradually, they also have so-called growth failure for children. Then lastly, may have some hepatic encephalopathy, even the liver decompensation, but only occurred in only a very late stage of the disease. So this slide shows the natural course of 62 patients published from Western countries. You can see the overall survival is poor, obviously. Then this 20 years we can see. 2 years, 5 years is okay, but if you 20 years follow up, the survival is not as good. However, we can see that's the overall and liver-related mortality. Actually, the liver-related mortality, the lower you can see is not very high, but somehow the patient died due to other reasons. But therefore, the overall survival is poor than the general population. But very few of them really died due to the liver-related event. So this is something different from cirrhosis. I think for cirrhosis, most patients will die of the liver-related death. So clinical manifestation, I already talked about. That's the diagnostic criteria. It is a disease of exclusion and also although have some pathological features. For example, the clinical sign of exclusion of the pre-hepatic and after the post-hepatic portal vein block. So that means the portal vein and hepectomy should be patent. Then excluding cirrhosis on liver biopsy. Then you by excluding other non-cirrhotic portal hypertension like congenital liver fibrosis. Then this disease can be diagnosed. So this, again, this slide is published by Professor. So it's portal hypertension, excluding cirrhosis, excluding pre and post-hepatic portal hypertension, excluding other forms of non-cirrhotic portal hypertension like congenital liver fibrosis. And finally, you have the features of this disease. So lastly, very briefly, I have 3 minutes. We talk about this disease. So it is easy to understand because it's not really liver cirrhosis. The liver decompensation rarely occurs. So the main goal, main target of treatment is portal hypertension. So here we have primary prophylaxis. We have non-selective beta blockers. We have endoscopic, okay. We have endoscopic vessel ligation. Then, of course, for the acute bleeding, you can control the bleeding like the portal hypertension cirrhosis. We also have secondary prophylaxis of vessel bleeding. We have non-selective beta blockers. We have anticoagulant therapy for portal vein thrombosis if it exists. Then we also have endoscopic. We have tips. We can also do surgical shunting plus splenectomy, which is very rarely nowadays used for cirrhosis, but it can be used for this disease because the liver function reserve is good. Then finally, for some cases, the liver, the portal hypertension is so severe, they can cause secondary cirrhosis, maybe due to other reasons. So that's the thing. Well, this is a slide from the publication from China, Japan, Friendship Hospital. You can see splenomegaly is the most commonly used method. They also, as I mentioned earlier, use endoscopy, use tips, and very rarely use liver transplantation. Then this is the survival post tips. You can see that the 60 months, I mean 5 years survival is quite good if you give tips, just relieve the portal hypertension. Well, this slide published from a paper published by Dr. He Fuliang. Now he moved to our hospital, a very small sample size again, but you can see the tips group have a similar survival curve with the surgical treatment, which is much better than just endoscopy and a beta blocker treatment. So this is just the thing tell you, we can use the tips perhaps, or we use surgery if TIPS doesn't work. But just endoscopy and a beta blocker doesn't work well. Finally, of course, if a patient have kind of liver failure, liver transplantation is still a choice. Lastly, this slide also published by Professor Sarin. He liked this kind of very busy slide, but we can see that the left part, the right part is actual hepatic portal vein obligation. So it's very complex, but just summarize is medicine, non-selective beta blockers, endoscopy, TIPS, surgery, and finally liver transplantation for very, very rare cases who did develop liver failure. I would like to thank you for your attention. Thank you.
Okay, so it's very good. The talk is in 15 minutes, but we are running out of time.
Okay.
So I'm not sure if you have any question on the floor.
No, we don't need to have to.
Okay, so so if there are no question, I would like to close this session. And thanks for Professor Jia for the last talk. I would like to invite the next session moderator, Professor Yo.
Good morning, everybody, and good morning, Professor Tawandi. I'm sure he's online now. Okay, so it's a great honor to introduce to Professor Tawandi, who is the elected president of APASL 2021. And the talk is very important because the epidemiology of liver diseases in Asian Pacific area. Professor Tawandi, please.
Thank you. Thank you for the introduction. Good morning, dear our President, Professor Jin Ho, Professor Jidong Zhao, our Secretary General, Professor Lai Wei, and most importantly, our President of this single topic conference, Professor Xiaolong Qi, for such a great organization. So in order to make the foundation for chronic liver disease, we got to have cover on the foundations of the causes of chronic liver disease, that is the cause of cirrhosis. So most of the portal hypertension going to develop after becoming cirrhosis, mainly. As you can see here, again, this is the study from Professor Sarin. So you know how important is Professor Sarin, because this is the collaboration between the Lancet groups and APASL to look at the importance of liver-related death in Asia-Pacific countries. As you can see in red is a percentage greater than 6% in Southeast Asia and in Mongolia, where China in the middle, from 3 to 6%. Then when we look at the causes of liver-related death by country, you see on the left is China. Majorities of the cause in our Asia-Pacific region going to be from viral hepatitis, mainly from hepatitis B, followed by hepatitis C. In some countries, for example, in Japan, hepatitis C predominates. Then when we look at the causes of cirrhosis as a cause of liver-related death, again, hepatitis B take the lead, followed by hepatitis C, and remotely with alcohol and other causes. And things remains the same for the cause of liver cancer. As you can see that hepatitis B account for more than 50% of causes of liver cancer, followed by hepatitis C and alcohol. Now, with the goal by WHO in 2030, in order to prevent new infection, as well as to detect those who already been infected and treat them accordingly. However, with the recent estimate, it's going to be very few countries that can achieve that goal by next 10 years. For example, in United Kingdom, in South Korea, for example, these may be the examples of few countries that can achieve that. But most of the countries remain behind. It is far behind, maybe by 2050. So that's going to be another 30 years to achieve the goal. However, the good thing for our region is the new infection is far less common. As you can see, all countries in our region can achieve the percentage of 1% carrier rate of hepatitis B. Actually, the percentage is going to be in just 0.8 in children under the age of 5. The good thing for many countries in Asia Pacific country going to be the availability of generic DAA. As you can see here, the country in green, either in dark green or light green, this is the country where generic DAA available. For example, in South Asia, in Southeast Asia, and in Mongolia. So these eligible for cheap treatment with the DAA. However, even with the same generic DAA, the price vary from country to country. The cheapest one going to be in India, but in the Philippines and Indonesia, the price is more than 100 times higher than in India. The third causes of liver cirrhosis going to be alcohol use disorder. This is a new term for alcoholic liver disease. As you can see, highlight in purple. So in Southeast Asia, in Western Pacific region, where our countries are, so you can see that from 30 to 50% of our populations are current drinkers. As a result, these account for alcoholic use disorder, especially in male, from 2% to 4%. This is going to be the harmful amount of the alcohol. As you can see here, so most of those who are current drinkers drinks alcohol from 30 to 50 grams a day. And actually, it's going to be higher and higher as times go by. So as we got more income, then we buy more alcohol. And alcohol itself accounts for almost 50% of liver cirrhosis worldwide. Moreover, in the countries where alcohol may interact with hepatitis B, this is a study done from China to look at the effect of alcohol and hepatitis B. So having both insults can have more fibrosis and more viral count in the patient with hepatitis B. As a result of harmful use of alcohol, the goal for reductions of alcohol by WHO by 10% in 2025. So that's going to be 5 years from now. We need to reduce the harmful use of alcohol by at least 10%, but we don't know whether this can be achieved because most of our countries still drink more and more. The fourth causes of liver cirrhosis got to be non-alcoholic liver disease. So it is now changed the term to MAFO or metabolic associated liver disease. For those who, especially for medical students and young investigators who are interested in this disease, please visit our APASL website for the guidelines of MAFO that just recently published a few days ago. So in Asia Pacific countries, we have set the criteria for overweight and obesity at the BMI less than in the Western country. And with that, you can see that almost 10% of our population are now in the range of obesity. For example, in China, this is a publication recently a few years ago. And as we go become richer and richer, so we gain more weight. And this is the preference of fatty liver in Asia Pacific countries published last year. So it's going to be the mix. Most countries will have more preference of fatty liver disease, but in many countries, for example, in Japan, the preference remains stable. This is the summaries of the preference of fatty liver in Asia Pacific countries. This is in China, India, Japan. So you can see that majority, about 15 to 40% of our population got to have fatty liver disease. Moreover, in Asia Pacific region, we have so-called lean fatty liver more as compared with the people from the West. Lastly, I just want to touch a little bit on less common cause of chronic liver disease, which is autoimmune liver disease, just for completeness of the cause of chronic liver disease. This is the summary of the study from in Asia Pacific region, from Japan, from China, from many countries in South Asia. Overall, autoimmune liver disease is not common, but it's not rare. The prevalence is about 0.5 per 100,000 population. And most of autoimmune liver disease in our region are type 1 autoimmune liver disease with female predominant. So in those patients with chronic liver disease who were negative for viral and also non-alcoholic and also negative for fatty liver, please don't forget autoimmune liver disease, because the treatment is quite promising. With type 1 autoimmune liver disease, remission can occur for almost 90% of the patient. So lastly, my conclusion, ladies and gentlemen, the epidemiology of liver diseases in Asia Pacific region nowadays, viral hepatitis is still the major causes of liver disease in Asia. However, with the implementations of the vaccination and the treatment of both hepatitis B and C available, especially for at a reasonable cost, then we're going to eliminate viral hepatitis as well as reduce the long-term complications of viral hepatitis. Then the cause that become more common got to be alcohol use disorder, fatty liver, and don't forget autoimmune liver disease. Thank you for your attention.
Thank you, Professor Tawandi. It is a very important talk, covers viral hepatitis, NAFLD, alcoholic and autoimmune hepatitis in Asian Pacific area. Hopefully we can control the COVID-19 fast in the Asian Pacific area and globally, and also it's better to come earlier than everybody can enjoy the Asian Pacific area, the APASL meeting next year in Bangkok, Thailand. We wish to see you there.
Yes, thank you so much, Hong Yu, and please be invited to the APASL annual meeting in Bangkok next year. I hope that, I think all Chinese going to be, you are going to be invited, and you're going to be free to travel to Bangkok by next 4 months. Thank you so much.
Thank you, okay. Wendy.
Thank you.
I will give to the next moderator, Professor Ho Jingling. Thank you.
Good morning. Now I would like to invite Professor Fu Seng Wang. Professor Fu Seng Wang is a director of Research Institute of Infectious Disease and Beijing Institute of Infectious Disease. Former 302 Hospital, currently the name changed to 5th Medical Center PL General Hospital based in Beijing. He will give us a talk. The title changed to High Cure Rate in Children with Chronic Hepatitis B, Early Antiviral Therapy. Any enlightenment, new titles. Fusen spent a lot of time on HBV, HCV, as well as HIV clinical immunology. More recently, also published a very nice paper on COVID-19 in Nature Immunology, as well as other top journals. Fusen, please.
Thank you, Professor Ho Jinlin. Thank you for a nice introduction. Also, I express my thanks to Professor Xiaolong Qi and also professors, organizers for your kind invitation. I'm sorry to give a minor modification of presentation title because the immune responses against the HBV infection is very interesting. But anyway, although there are some progress in the field, but most of us physicians are more interested in the cure of chronic hepatitis B. So why there is a high cure rate in children with early antiviral treatment? I want to address the three aspects. Just a moment ago, Professor George Law mentioned 3 Nobel laureates. There, 3 of them, like Dr. Otto, he is a physician. He made an original clinical identification of the HCV diseases. And Dr. Orton first identified the pathogen is original basic research. And also Dr. Charlie Rice is also established the replicant. Also, this is a very good platform for identifying their drugs for cure of this disease. So basic research is very important. Original research is very important. But anyway, I also address the immune responses in chronic hepatitis B. As we can see, in healthy person, there are 3 functions of immune systems are normal, are very good about their immune defense, immune homeostasis, and immune surveillance. However, in a patient with a chronic hepatitis B naive treatment, the immune defense, there are some problem, innate immunity and adaptive immunity, especially HBV specific adaptive immunity. The second is the immune disorder lead to the liver inflammation and fibrosis, and then even to the HCC. My question is, there are any difference between the adult patient and the children patient? The answer, it is. This slide just tells us that because of their vaccination, the prevalence of surface antigen positivity become lower and lower, not only in China, but also in the world. And then, although the HPV vaccination is available, however, there are some failures of the HPV transmission from mother to infant. So this leads to the children with chronic hepatitis B. And then in China, compared to 20 years ago, the surface antigen prevalence becomes very lower. Also, it seems there are some difference between the urban area and the rural area. And then we must know in children, the spontaneous E antigen seroconversion is low. But however, the surface antigen seroconversion is extremely low. It means it's almost, if the children did not receive antiviral treatment, it's hard. It's very difficult to get cure. Right now, just 3 or 5 years ago, AASLD, ESA, and then APASL issued the guidelines to treat their children. This is just 3 or 5 years ago, but 10 years ago, no guidelines. At that time, the question is, the children, if they suffer from chronic hepatitis B, should they receive antiretroviral therapy? And if the children is acute, acute phase, should they receive the antiretroviral therapy? Right now, the answer it is, but 15 years ago, we don't know the answer. It's very careful to treat the patient 15 years ago. At that time, some physicians in our hospital, they are pioneers to treat the patient. So this is a non-benefit of interferon alpha therapy for children who are immune active phase. Here we can find more than 400 children with chronic hepatitis B E antigen positive. The age is under 17 years old. They are divided two groups. 116 patients, children, received interferon therapy, 72 weeks interferon therapy. But other 95, no treated. This is ethical, is no problem. And also, these patients received more than 13 years follow-up visit. How about the data? This is the baseline data. There are no differences between the two groups. The age, the source of infection, the ALT level, the HBV DNA level, no difference. But if these children received 72 weeks interferon alpha treatment compared to their untreated, we can find the differences in ALT normalization, HBV undetectable level, or even in the soft antigen loss. We can find in the treated group, the soft antigen loss is about 11, but in the control group, the soft antigen loss is only 3%. It's a big difference. This cartoon is very interesting. We can find that if the patient divided into two groups, one group is treated, other is untreated. We follow up, we have the 13 years follow-up check. We can find in the treated groups, the cumulative rate of the soft antigen loss goes very high. That is about, how to use the mice, about 50%. But in the untreated group is only about 20 or 25. How about the cumulative rate of E antigen loss? There are big differences between treated and untreated. It's very interesting. If we divide the patient into two groups, the age is less than 7 years old, and age to 17 years old, we can find in the treated group, the E antigen loss is very high. Also, the ALT levels, the plasma HBV DNA levels influence the E antigen loss. For example, if the ALT level is very high, the E antigen loss rate is much higher. This is in the untreated groups. We can find almost no differences to the 13 years cumulative rate is no difference between the two groups. If we further analyze the patient, we can see about the soft antigen seroconversion loss, soft antigen loss is less than 7 years old. The soft antigen loss is close to 75%. But in the patient age to 17 years old, the soft antigen loss rate is only about 30%. 30% is a big differences. But in the untreated groups, if even we divide them into the two groups, it seems low differences at the third year. It's very interesting. If after the 72 weeks, if there is a E antigen loss, we divide the patient into two groups. We can find in the E antigen loss, we can find the soft antigen loss is become much higher compared to the E antigen positive. Well, you may concern about the side effects. Yes, there are some side effects, like fever, neutropenia, and then decrease the appetite. But very interesting, after you stop the interferon treatment, only 6 months later, all their parameters become to normal compared to their untreated children. It means this interferon therapy does not influence their growth rate and some parameters. We just also summarize the data. If we divide the data, the children under 7 years old, like 1 to 3, 3 to 5, this is more than 3 to 5, and then this is 5 to 7. We can find that the surface antigen loss becomes much higher if their age is under 3 years old. How about the e-antigen negative children? It is also very interesting. In 1 to 3 years old, in the e-antigen children, if they received 1.5 year antiviral treatment, the e-antigen negative rate is very high. It means the under 3 years old children with chronic hepatitis B are the best time to receive antiviral therapy. So there are two impressions. One is 72-week interferon alpha treatment was safe and effective with a higher cumulative rate of e-antigen and surface antigen loss in active chronic hepatitis B patients, especially the patients under 1 to 7 years old. The second is almost the same. The younger children, the earlier antiviral treatment with the higher, also if they're with a higher rate, higher serum ALT levels or less, the lower HBV DNA levels, that has a higher rate of a cumulative rate of surface antigen loss. You may ask a question, if their children is immune tolerance rate, should they receive antiviral therapy? It is controversial. Not only in China, in Eastern country, but also in Western country. This is very interesting. The patient sample size is not very high, but you can find significant differences in that patient with immune tolerance phase. In that patient who received 1.5 year antiviral treatment, there is almost 20% of them has a soft antigen loss, but in the control, 0. It is a significant differences between the two groups. You may ask why there are some other groups report the immune tolerance phase in the patient who received antiviral therapy, the surface antigen loss rate is very low. I compare the two groups because the ages, the children, the sex are different. And also the treated, the interferon are different, probably lead to the differences between the two groups. So for the patient with immune tolerance, if they received antiviral therapy earlier, the cure rate is much higher. What's the reason? Why the children has a higher cumulative rate of surface antigen loss, even surface antigen seroconversion? Probably there are 4 reasons. One is that the children have a very small livers, like this size, but in the adult is very high. The second is the new generated hepatocyte will not be infected by HBV pathogen because there is a full viral suppression in this patient. The third is the HBV cccDNA viral reservoir is very small in this patient. The last, the immune system are big difference because the lymphocyte is very high in the children, especially under the 6 years old the children. So in the future, it's better to further identify why the patient, the children under 6 years old with chronic hepatitis B received antiviral therapy, the efficacy is much better. And then also, what reason lead to the differences? And then, but so far we still don't know whether interferon alpha or nucleotide, which antiviral therapy regimen is much better. This needs to be answered. Sorry, this slide is Chinese, but it's okay for us. Probably for the chronic hepatitis patient, not only in children, but also in adult patients, we can use the single cell RNA techniques to analyze not only in the peripheral blood, but also in the liver biopsy samples. And also not only in the immunological parameters, but also the parameters, including virological parameters, we can find some differences. And then, yes, we did find some differences in the children, not only in the peripheral blood, but also in the liver samples. We found the immune tolerance phase, the immune responses are different within the liver samples. So in the future, we should run randomized controlled prospective studies, even multi-cohort studies to further verify, to further confirm the efficacy in the children chronic hepatitis B patients, and then when they received antiviral therapy. And at the same time, we should compare the two age groups, why there are differences between the children and the adult. This is the last slide, probably in the future. Right now, we have the nucleotide analogs, and we have the interference to suppress the viral replication. But we are lack of these two kind of drugs to suppress the surface antigen, to suppress the cccDNA. We hope the new drugs comes out in the future. We hope the novel immune therapy can suppress the surface antigen, can suppress the cccDNA, and then more patients become functional cure or clinical cure. Thank you very much. I also express my thanks to Professor Zhang Min and my student, PhD student, Dr. Wang Limin, and my colleagues. Thank you very much for your attention.
Thank you very much for your excellent talk, Professor Fusen Wang. Sorry, due to a big behind of time schedule, so anyone from floor could communicate with Fusen after this session of meeting. Yes. Thank you. I think it's a very, very nice talk. Thank you.
Okay. Now we will continue the session. I'm Wen Hongzhang from Shanghai Fudan University and work in the Huashan Hospital. I'm very glad that today we will invite Professor Wei Lai to give the talk. Professor Wei Lai, he's Vice President of Beijing Tsinghua Chang'an Hospital, and he also is Secretary General History in APASL. Today, he will give a talk about a very hot topic about the COVID-19 and the liver injury. Please welcome.
Thank you, Professor Zhang, for your kind introduction, and thanks the organization, Professor Qi Xiaolong, Professor Jin Ho's kind invitation to give a talk. I was assigned to discuss the COVID-19 and liver injury. Up to yesterday, and we still have some of the new cases of the COVID-19 and global wide. And particularly in some countries, in the patients and the new cases, new diagnosis patients still increased. So therefore, and from this WHO the website, you can find that totally is more than 35 million people and the confirmed cases of the COVID-19, including and the 1 million and the deaths. So therefore, is included and the more on the country and the more cases and the more deaths. So it's implied in the more and more patients we need to understand them inside for COVID-19. But actually, we know COVID virus for a long time. And in here, and then you can find the in common cold, the one on the biggest cause is the COVID virus. So, and if you look at this table, then you can find the top reason for common cold is the rhinovirus. The second one is coronavirus. And it accounts for 10% to 15% of the common cold and due to the coronavirus. And however, today we face the new type of coronavirus. And before we discuss the new type of coronavirus, we can and take a review for the SARS and the MERS. In SARS and the MERS, if we combine the two kinds of the list of coronavirus infection, then we can find some features for clinical and laboratory findings, including fever, cough, or shortness of the breath, and diarrhea, and chest radiography abnormality, and the lymphopenia. And however, you can find in the SARS, and more patients have the lympho and the penia, and a little lower in MERS. And however, the cough and shortness of the breath, a little high percentage in MERS, a little bit lower in the SARS. And the way is the liver injury. You cannot find here, but if you mine in the literature, then you can find and the SARS and the MERS, you can understand some and the differences. In SARS, you can find in this kind of the new coronavirus infection, and among the 10% of patients underlying the chronic liver disease. And however, we have to know that these and the kind of new coronavirus and the prevalence in the Asia. So therefore, the HBV infection is around 10% in this kind of the population. Regardless, the abnormal liver function test is around half of the SARS patients and show us the abnormal liver function test. And however, it's pretty high and in most populations, it's around the 90% to 77%. And if the patients with the worst and the outcome, then the abnormal liver function test and occurred in around the 90% in these patients who has the worst and the outcome. And if the patients they did not and show that worst and the clinical outcome, they still have the high percentage with the abnormal liver function test. And we still can find in SARS populations the ICU admission and the death and the occurring to the people who have the high ALT level. And however, it MERS in the high and the ALT admission and death, and usually and occurring to the people who has the comorbidities. So let's go to the COVID-19. So how about the COVID-19 and the hepatic dysfunction? And up to now, actually, and the most of the study just look at the so-called liver function test, and actually it's the liver biochemistry. When we look at this table and just published in press, summarized at a few of the studies reported and abnormal and the liver function test, and in which most of the study came from China. And in addition, a few of the study came from China, and we still have some data from Italy and the USA. And if you look at the right side, then you can find, in including and the different percentage for the ALT, AST, and the GGT, and the elevation. And meanwhile, you still can find the percentage differences, and something is lower, such as the in 7%, and also some higher to the and half of the patients, some to and the 15 to and 30%. And then we also still can find in someone and with and had the underlying chronic liver disease, and also the patients and with the high mortality with the and the high percentage acute liver injury and up to and 77%. So therefore, it's the various among the populations. And also you can find here, and the Dr. Wu reported the bilirubin and was significantly higher in patients with the ARDS related deaths. And I also mentioned this kind of the bilirubin and the significance later. And also, if you look at the Italy and the US study, then you can find still and have the very similar and the ALT or AST and elevated and with the Asia and China report. So what's the reason? What is the etiology for the liver injury and the liver and the biochemistry abnormality in COVID-19 populations? And a few of the clinicians and they give the comments for that. Is here you can find the top one is the SARS and the virus. I mean the COVID-19 virus. The virus already show us they have the direct and the injury and on the liver and the cell and hepatocellular hepatocytes. And in addition to the virus direct actions, then maybe we can have some and the other etiology and the mechanisms, including and the drug induced and the liver and the injury, because and the COVID-19 patients, particularly at a very early stage, that we give the patients many drugs and medications, and these medications may have some and the drug induced and the drug induced liver injury. Also, what we have to know is the drug-drug interaction. The drug-drug interaction also can induce and the drug-induced liver injury. In addition to these, the two top reasons, and some and the 40 that in ischemia and cholestasis of the sepsis, and also the non-liver and the origin of chronic liver disease, the underlying, and also an alcohol and the basic and the hepatic congestions and the biliary and the dysfunction and other virus hepatitis. So therefore, and if you have the patients show you with the high ALT and AST, even for the bilirubin, and we have to do some of the differentiation diagnosis very carefully and very detailed. Then you can give the patients the correct treatment. So, and what do you have to know? If the patients have the pre-existing liver disease already, and what will happen in COVID-19 patients? And here, and we have some of the paper, and the paper and show us the pre-existing liver disease. Here, and I summarize the patients with the basis of the baseline with the cirrhosis. Then you can find from analysis studies, and even the patients with the cirrhosis at the baseline, the outcome is still differences. In this table, the top one you can find in the number of deaths or prognosis in the patients with cirrhosis is 0. And however, if you look at the lowest one, and these the two papers, and the reported and the 400 and the 298 patients, and respectively. And if you look at the number of the prognosis of the patients with the cirrhosis, is around 33 and 36% and also 31%. So therefore, ND4 populations with the pre-existing liver disease and the COVID-19 and people, and we should be very careful for their and the worst and the outcome. So we have to get these patients and monitoring and closely. And the question is that for some patients, they may have the HCC hepatocellular carcinoma. The hepatocellular carcinoma is the worst end of the liver disease and impact of the lifelong and the patients. If they increase the patients for the mortality, and so how about this kind of population infected with the COVID-19? And here, and I give you an example. The data came from a national-wide study of the 1,519 cancer patients and infected with the COVID-19. And for the data collected from the 575 the hospital in China, and the people and the patients with cancer were at the high risk of contraction and the COVID-19 infection and developing the severe and the serious. And so they also have the worst outcome compared with without the cancer patients. And let me look at the left side. Now here, in the up one, the blue bar and indicated with the angiogenesis and also more in the comorbidity. And the pink one and show the patient and with the ICU administration or maybe death, but a little bit on the good compared with the blue bar. Then you can find the probability of the events is so high in the patients in the blue bar. If you look at the lower one in the left, the blue and the cove indicate the patients and with the cancer, without the cancer. And however, the green one indicated the population of patients with the cancer. So the probability of the severe events is increased over the time within the 40 days. And the peak is around 20 days. So therefore, in the very early stage, in the first 3 weeks, if the patients, COVID-19 patients with the HCC, we should and careful for the patients with the worst and the outcome. So, and how about the liver transplant patients? Liver transplant patients, and if the patients have to receive the liver transplant, it may be delayed due to the COVID-19 infection. And however, how about the patients who already have the liver transplantation historically? And the two groups reported in this kind of situation. The first one is the 40 pediatrics, and totally is the 700 and the pediatric liver transplant recipients, and in which the number of the COVID-19 is 3. The incidence is around 0.04, and also then you can find that the better and the worst outcome is 0. And if you look at the adults, and the adults was reported in this study is the 151 patients, and the total is the 6 patients infected with the COVID-19. And the worst the outcome is the 1.9. It's low and so very high compared to the patients without the liver transplant historically. So therefore, and for this kind of patients, and we have to low others. What is others? I means 40 and the received and immunosuppressed treatment. So and we and pick up and the 2 cases. The cases, one is a 37 years old man with the hepatitis B and the HCC historically, and these patients developed a fever on the 3rd day and passed and trace, and then he confirmed the COVID-19 infection on 3rd weeks. Then forward, his tacromos and dose was reduced and maintained on the 10 and nanogram per ml. And however, his liver enzyme increased by the 4th week, but steadily and greatly. His PCR remained positive for nearly 2 months and subsequently clearing. So it's implied the patients may have the liver and the enzyme increase. And however, the challenges for this kind of patients is for the long-term and the virus infections. If this kind of patients and can develop to the chronic infection of the COVID-19, we still have to watch this kind of patients. The second case is a post-transplant COVID-19 patients who underwent cardiovascular liver transplant and in July 2017. And this and the peak of the COVID-19, these patients presented with the high fever and also developed the severe COVID-19. And also his tacrolimus was discontinued for a month, but he received the corticosteroid therapy due to the COVID-19. And even the patient's cessation of the tacrolimus, but under the corticosteroid treatment, and the graft function remained normal. So therefore, the liver function keep normal. So how about the management and the treatment? And actually, we know from our patients, one kind of the patients as abnormal liver enzyme, we shall give this kind of the patients give the treatment for the COVID-19, not in the liver, and stop the potential and the delay and the medications. The second kind also for the pre-existing liver disease, such as the HCC. For this kind of the patients, we can give the patient surveillance and the delay by 2 months. And however, in the treatment should carry out. And regarding the post-liver transplant, just to give the monitoring. So, and what remains? We still and have to do and after and the COVID-19 errors. And we have the so-called and the disease name and hypoxic hepatitis. And this kind of disease is the most of the due to the shortage of the blood and shortage of oxygen. The diagnosis criteria including a clinical setting of cardiac and circulatory and respiratory failure, and also a dramatic but transient rise in ALT. Of course, we have to exclude of other causes of the liver cell necrosis, and especially in the virus and drug-induced hepatitis. So, and because in the COVID-19 patients, usually some of the patients can develop TUDI and the ARDS and the cardiac and the failure. So therefore, we have to look at this kind of the patients in the future, even the patients recover and from the COVID-19, because hypoxic and hepatitis associated with the 1 and the better 1 years the survival infection and the cardiopulmonary and the gastrointestinal and renal and the hepatic complications. And in particular, in the hepatic complications, we have to look at the secondary and sclerosing and the cholangitis, SSC. SSC and actually and already described and during a following and significant and the critical areas and associated with the severe respiratory insufficiency. So and maybe and we should and keep an eye on this kind of an outcome in our COVID-19 recover the patients. So, ladies and gentlemen, I want to conclude here. And the COVID-19 and the liver, actually, and hepatic dysfunction has been seen in 14 to 50% of the patients with COVID-19, and particularly in the patients with the severe disease. And cases of the acute liver failure has been reported and are associated with the high mortality. And last, the effect of COVID-19 on underlying chronic liver disease required detailed evaluation and even follow up for a long time. Thank you.
Many thanks for Professor Wei give a wonderful talk about the COVID-19 relationship with liver disease. I think we should have more time to discuss about this topic. However, now almost 1 hour later, I'm very glad to have the time today preside for Professor Wei. Thanks very much. Also for the invitation from Professor Qi. And now we will move to next session.
Thank you.
Morning, everyone. Now comes the last topic this morning. The speaker is Professor Xiaolong Qi. He is working the first hospital of Guangzhou University. He also is the assistant dean and chief of the portal hypertension center. The first, and also the chairman profession community of portal hypertension, China Association for Promotion of Health Science and Technology, and also is the initiate of CHASE. Of course, he is also the chairman, of current single topic conference. The topic of Professor Xiaolong Qi is the CHASE research ongoing and planning. Professor Qi, please.
Thank you, Ken. Introduction of Professor Chen. I would like to share our recent study, which is called the CHASE Ongoing and Planning Trial. So all of our research aim to change practice in the field of portal hypertension. I'm the founder and chair of CHASE group. So since 2016 until now, we have initiated 15 the prospective multi-center studies. And among these, we have around half of them, around 8 trials, is related to the diagnosis of portal hypertension, either of the radiology or the laboratory medicine or the ultrasound or some the capsule endoscopy. And the other half is about the treatment, including the drugs, therapy, endoscopy therapy, interventional radiology, and we still do some follow-up for the prognosis. So all of these 15 trials is aimed to change practice from the different angle of for the portal hypertension patients. And currently, if you search with the keywords CHASE and portal hypertension in the PubMed, we have already published 29 papers during the past years. And you can see in the 2017, we have only 2 papers, but in this year, we already have 14 the papers named CHASE and portal hypertension. So we increased dramatically. For the completed trials in the past years, at the very beginning, we have a paper demonstrate based on the 3D construction and the computational fluid dynamics for the portal pressure gradient simulation and in the gut. And our really first trials, we call CHASE 6001 trials, published in the radiology. We reported the Virtu hepatitis venous pressure gradient based on the CT images is available, and we use the invasive HPPG as the reference standard. And very lucky, the last month we just got the United States patents of this technical, and we just translate this the technical into the imaging post-processing workstation, and hopefully we will get this the marker the late this year. And the second of our trials, we develop and validate a radiomic signature for the clinical significant portal hypertension. This CHASE 1701 trials in the Lancet Series Journal in Biomedicine. And the first trial in 2018, we tried to develop the magnetic controlled capsule endoscopy for assessing risk of varices bleeding. And it's a real novel technique developed by the Chinese company called Anhan. And it's a really dramatically improved the patient satisfaction for the fitting of the anoscopy. And this technique also highlighted in the Nature. And our second trial in 2018 is we try to develop a non-invasive score using non-contrast enhanced MRI for the clinical significant portal hypertension, and we report our midterm results in the Lancet. And very recently, we have another publication in the clinical gastrohepatology, and we try to use the artificial intelligence in technical deep conventional neural network aided detection for the portal hypertension based on the two large cohort, one is the CT cohort, one is the MRI cohort, to develop this technique. And for the about the COVID-19, we published the first prospective multi-center case registry study to report the clinical cause and risk factors of a mortality of COVID-19 patient with pre-existing cirrhosis in the gut. And based on this cohort, we also have another publication to report the potential direct injury of COVID-19 viruses on the liver injury in the Journal of Hepatology. This is our past trials. For some ongoing trials, one is our collaborator with Professor Hongwei Zhou, who is the very famous the experts in the microbiome. The first trial of our 2019, we want to demonstrate that if the microbiome or peptide-based models can be used in non-invasive detection for the high-risk viruses. It's our ongoing trials. And the fifth trials of last year, we try to establish a chest acute viruses bleeding. It's a database. And in this cohort, we have 34 sites from 30 cities in China. We totally enrolled acute GI bleeding more than 12,500 cases. And among them, acute viruses bleeding is more than 3,000. So we just analyze this cohort and try to get them the results. I would like to highlight this study, the first trials in this year, because currently we only care about patients with decompensated cirrhosis, right? So for all these patients, maybe they already bleeding, have ascites or the HE, but the median survival of this patient is very limited, is around 1.5 years. But really, we really care about patients with compensated cirrhosis. But unfortunately, in the current practice, we cannot enroll this patient into a clinic. It's always in the outpatient of the Department of Hepatology or the Department of Infectious Disease. So we really care about this patient because this patient, the median survival is 15 years, is 10 times more than the decompensated cirrhosis. So based on the Baveno consensus and the Chinese Society of Hepatology, we recommended anoscopy for the screening of viruses, but unfortunately, we didn't do it in the routine practice for the compensated cirrhosis. But we have a lot of reasons. I don't have the time to give into details, but we really have a non-invasive procedures because if we can measure liver stiffness, if they're less than 20, and measure the platelet more than the 150,000, the patient has a very low risk of a reversible required treatment. So the patient can avoid screening anoscopy. But unfortunately, in Chinese practice, we didn't use this criteria, right? And 2 years later of the Baveno consensus, a group from American, they improved this criteria. They call the expanded Baveno criteria with the liver stiffness around 25 and a platelet around 110. But they concluded that expanded Baveno criteria performed well in HCV, alcohol-related cirrhosis, and NASH-related cirrhosis. And our recent paper also validated the Baveno expanded Baveno criteria works well in the MAFR-related cirrhosis. But we really care about HBV-related cirrhosis because if the patient is HBV-related cirrhosis, the liver stiffness is around 18. But if it's an alcohol-related cirrhosis, the liver stiffness is around 23. So there is a big gap here. So based on this background, we initiated the first trial this year. We enrolled from 23 sites, more than 3,000 the compensated cirrhosis patient. And we want to develop a CHAS criteria, which we want to explore the cutoff value for the liver stiffness and platelet. And in the real world cohorts, we collaborate with the Tianjin Second People's Hospital it's a 5-year real-world cohort around 1,234 patients. And the validation cohort, we have 18 university hospitals we enrolled in the past years. And you can see HBV is the main etiology in Chinese chemosynthetic cirrhosis. And expanded Baveno criteria means a great number of viruses needing treatment, high risk viruses, more than 6%. So we can't use these criteria in China. But if we regarding the use of Baveno criteria, only 30% patient can spare endoscopy. So we still need around 70% patient need to use the endoscopy for the confirmation. And based on the chest criteria with low cutoff of liver stiffness, we have around half patient can spare endoscopy. And this is a really cost-effective method for the screening of viruses. And in the validation cohort, we demonstrate the same results with the chest criteria significant improved rates of spare endoscopy than the Baveno criteria. We really care about what kind of research is really beneficial the patient. So we try to use this chest criteria to guide the practice. And we have done for example, just in the People Hospital of Ningxia, the region, we enrolled the chemosynthetic cirrhosis 120 patients and come around 100 patients. And the chest criteria define the high-risk patients is only 16. That means 84 patients can avoid screening endoscopy safely. But according to current practice, we need to endoscopy for every chemosynthetic cirrhosis. We saved more than 80% endoscopies. And for the 60% high-risk patient, they received the endoscopy, and 6 of them is a high-risk patient. Just give you an example, it's a 53 female lady with hepatitis B, chemosynthetic cirrhosis 10 years, and no chemosynthetic cirrhosis before, with a very high risk of liver stiffness, but very low platelet count. And this is the chest criteria define the high risk versus. And we recommend the patient to receive the endoscopy. You can see the very severe versus here, and also with the red mark. But in the current practice, we may miss this patient, and we do the first prevention of this patient. Besides the hepatitis B, the schistosomiasis is also the very important issues in China. So we try to collaborate with several the special centers focus on the schistosomiasis, portal hypertension. We try to develop a special criteria for this kind of the population. So summary, the chest criteria guided. We have already done the 10 centers use the chest criteria to guide clinical practice. More than 30% can safely avoid screening endoscopy. And among the patients receiving endoscopy for the confirmation, more than 30 patients was confirmed by the endoscopy. So this is really a very good non-invasive tool to help us to do the risk stratification of the chemosynthetic cirrhosis. From the planning trials, we have 3 trials this year. We try to collect the TIPS cohort, which we have the 105 sites in this cohort from 52 cities in China. And later on, we will have initiated our 4th trial this year. Is about the spring stiffness for the portal pressure measurement. I would like to highlight this study. We try to evaluate who is a high risk, who is a low risk. But we need to quantify the viruses at first. But currently, people always just judge the diameter versus diameter by eye, by experience, no ruler for that. So based on this, we develop a tool we call the portal hypertension versus ruler. It's a very simple the skill. Just we put a lot of the marker here, 1 millimeter, 1 marker, and you use this very simple tool can give the exactly versus diameter. So we already got the patents. We already have the performance, the allows of to sell this the patent. And then we will have initiate another study, which already have 300 hospitals will participate in this trial. We need to do the the quality control of the portal hypertension versus the endoscopy report for these trials. So this is a brief summary of our trials in the past 5 years. We already initiated the 15 trials in the past 5 years, and every year we will initiate 5 to 6 the prospective multi-center trial in the national class, and we also have the provisional class, the Portal Hypertension Alliance this year, and we will have more than 30 or 50 prospective provisional the cohort the year. We really, by doing this, we really need a very the support from some big head and some hero in this field. But we really thank every ordinary physicians and every ordinary researchers to take part in the chest trials in the past 5 years and in the near future. Thank you very much.
Thanks for Professor Qi's wonderful talk. I think maybe a question to talk with Professor Qi. However, time is too late in morning, so I had to end the session. Thanks, Professor Qi.
Thank you.时间关系，我们直接进入下一个 session， 然后刚好也跟这个sorry English， so we need to move on to the next step. It's a good time for the next session because this is our next trial this year, 2004. We try to evaluate the spleen stiffness because currently in the clinical practice we only use the liver stiffness to evaluate the port pressure or evaluate the fibrosis. And but all of us know the spleen is very important the organ for the portal hypertension. So based on this background, we will initiate our the 4th trial this year. It's about the spleen stiffness combined with liver stiffness for the evaluate of the portal hypertension. Professor He, please.
尊敬的各位专家教授，中午好，我是何蕊玲。接下来由我来介绍 CHEES 2004多中心研究方案，基于异成像技术的脾脏硬度和肝脏硬度联合模型对门静脉高压高风险静脉曲张的预测价值。门静脉高压是肝硬化患者的主要并发症，临床表现包括腹水、食管胃静脉曲张出血、肝性脑病等。HVPG 是诊断门静脉高压的金标准。美国肝病学会共识对肝硬化门静脉和分期 HVPG 5到10毫米汞柱称为轻度门静脉高压，大于等于10毫米汞柱称为临床显著性门静脉高压，大于等于12毫米汞柱称为肝硬化门静脉高压失代偿期。2018年，中国 HVPG 临床应用专家共识指出 ，HVPG 大于等于12毫米汞柱是发生静脉曲张出血的高风险因素。此外 ，HVPG 还能够评估药物治疗的反应，以及预测选择内镜下套扎治疗的时机。但是 HVPG 的测量对技术水平要求很高，通常需要进行多次的侵入性检查，才能够准确评估门静脉高压并发症的发生风险。食管静脉曲张不良也是肝硬化最严重的1%，死亡率约有15%。EVB 的风险主要取决于静脉曲张的大小。胃镜检查是诊断食管胃静脉曲张 （GOV） 及评估其出血风险的金标准。但费用昂贵，易引起患者的不适，且大部分肝硬化患者并未出现高风险静脉曲张，因此胃镜检查并非是一项理想的筛查方法。为了减少肝硬化患者 GOV 风险评估时内镜检查的过度使用，巴维诺6建议基于吮食弹性成像 TE 测量肝脏硬度小于20千帕且血小板计数大于15000的晚期代偿性肝硬化患者，30%可以安全的避免胃镜的检查。为了扩大这个筛查的标准，扩展的巴贝诺6提出，通过使用肝脏硬度小于25千帕且血小板计数大于11000，40%的患者可以安全的避免胃镜检查。但值得注意的是，巴贝诺6以及扩展的巴贝诺6会议都是根据欧美的代偿期肝硬化队列来制定的，其中慢性乙型肝炎患者的占比很少。2017年 WHO 报道，全球约有2.57亿 HBV 感染者，每年约有88.7万人死于 HBV 感染的相关疾病。亚洲 HBV 地方流行程度也各不相同，而在我国，2019年乙型表面抗原阳性的流行率约为5%到6%，慢性乙型肝炎患者约有8000万例。既往的研究表明，肝脏硬度与门静脉高压的严峻程度有显著的相关性，但肝脏硬度仅在门静脉高压的早期阶段与门静脉压力有良好的相关性，因为早期阶段肝纤维化成分占主导地位，而在晚期，高动力循环和门静脉血流量的增加，脾脏硬度可能比肝脏硬度具有更好的相关性。众多研究表明 ，LSPS 模型也可以用来预测临床显著的门静脉高压。2019年发表在 Hypertension 上面的一篇文章，它的研究方法是对于高风险静脉曲张的患者进行预防性卡维地诺药物的治疗，并在治疗前以及治疗结束后分别测量 HVPG、肝脏硬度以及脾脏硬度。卡维地诺治疗的血流动力学。
I'm pleasant to have the privilege of representing our project team to present the recent data on the relevance of histologic fibrosis in decompensated cirrhosis. This is a funding support for this project. As we know, acute decompensation of cirrhosis carries a high risk of short-term mortality. And the Turco Pew score and model for end-stage liver disease SML are widely used in ADC, but they are easy to use, but have only moderate prognosis performance. On the other hand, the assessment of HEPG and histologic studies such as Linux staging, that is semi-quantitative staging, or the quantitative collagen proportionate area, that's a CPA, has been used for predicting prognosis in cirrhosis, but very limited in decompensated cirrhosis. Therefore, in fact, currently data on histologic study for ADC are very limited, and the prognosis value of histologic data remains uncertain. Very recently, evidence from the pioneering work of our group and the other group as well suggest that quantitation of collagen patterns by computerized assessment of multifunctional microscope can be used to assess the liver biopsy specimens with various liver etiology. There is some of the milestone work, translational work we collected, where we show that this idea can be feasible for the hepatology research. And this project, we collaborated with the physician scientists and their cohorts with distinction for a particular chronic liver disease, and we validated the idea. So based on this, we initiated a novel method for analysis of liver fibrosis. We named it the quantitative profiling of fibrosis parameters. And we think which may be considered as an alternative to current histologic system for analysis of liver fibrosis. But we know that as for cirrhosis, there are many distinctive features of the fibrotic pattern, which is from those of the non-cirrhotic stages. So based on our technical strengths and the current understanding of cirrhosis patterns, the features, we built a dedicated tool for determining the collagen patterns. And it showed that it has high accuracy in describing cirrhosis remodeling in CHB liver biopsies. And we named the tool QCP. And the data show that QCP can have high reproducibility and high discriminate performance to telling the substage of cirrhosis by the ESHAC system. And then we thought about whether we could use this advanced technology to read the complex fibrosis together with Professor Ring and Professor Chagan Bihari in the LBS team. So our hypothesis is that measurement of collagen pattern could be clinically relevant and useful in assigning prognosis. Because this is the very first study that uses advanced technology in reading the advanced sources. So our aim is to assess ability of QCP, first to reflect the disease pathophysiology, and next to predict the risk of short-term mortality in ADC. As for the subjects, patients admitted from 2012 to 2014, and with the histologic cirrhosis and had diagnosis of acute composition were considered for inclusion. Out of them, we excluded the ones younger than 18 years, have liver biopsies over-fragmented and shorter than 5 millimeter, have no clinical data within 7 days of liver biopsy, had gone liver transplantation, or has a diagnosis of malignancy or hepatic vascular diseases. And finally, we got 413 eligible cases that we use for the histologic test cohort, that is to validate the relevance of pathophysiology. And out of them, we got 227 which have the follow-up data to use for test the prognosis relevance of tool. So we collect the clinical data, including the conventional end-stage liver scores, for example, like MEL and CTP. We also collected EGPG, which is measured during the liver biopsy. All these biopsies will also be measured, be staged with the conventional histological pathologic system, such as the LINAC system. It should be noted here that shown in this table, you can see that the basic concept of LINAC is in fact mostly about two atoms, nodule and septa. So the determination is based on estimating the size and number of these two atoms. So that is LINAC. Here we show the basic characteristics of the cohort patient. You can see that the both cohort has the average age of 28, and they are mostly male patients. The most common etiology is ALD, and next is AIH and NASH, and then viral hepatitis. And they have the MEL score around 15. And most of them are LINAC 4C. They have liver biopsy longer than 10 millimeter, so that is good. And the mortality rate of the follow-up cohort is about 50%. So we next determining the collagen patterns of these cirrhotic liver biopsies following the procedures established in our laboratory. And then that means that we measured the image parameters, the comprehensive image profiles of the parameters with quantitative values for these patients. The profiles is called the QCP. So in comparative analysis, we tested the relevance between the QCPs and the clinical variables. So in analyze the histological correlation, we first compared the QCPs among etiologies. You can see that we divided the groups into two groups according to the LINAC system to avoiding the disturbance of histologic severity. In LINAC 4C, they are more significant, longer, broad collagen fibers and more complex, well-spread and diverse distributed sinusoidal fibrosis in ALD, but they are denser and septal fibrosis in HCV and NAH. Another group with a lighter, with milder LINAC stage, called milder LINAC stage. Fibrosis is more extensive and complex with more numerous, longer and broader collagen fibers sinusoidally in ALD, but was less complex in NAH and NASH. And then we compare the data among the next stages. And according to the data, I didn't show it here because there are a lot of data there. So I summarize descriptions. From stage 4A to 4C, we can see septal area and nodule density increase in stepwise manner. That reflects the basic concept of next staging. And more than that, we found that 97% of QCP parameters show statistical significance in the stepwise value shift, revealing a more comprehensive depiction of evaluation of fibrosis patterns. And as for the, and then we move on to test the independent impact of the clinical pathologic factors on the QCP parameters. And we found that next stage is the most powerful factor on the QCP parameters. And next to it, MEL score is a major one, is a major impact factor to it. Platelet count, patient sex, etiology, PG only weakly impact some of the QCP parameters. And to our surprise, age had no impact on QCP parameters in this cohort. And then we move on to use the follow-up cohort to test the short-term mortality ability of these models. You see in this table is based on the URC test, QCP model has the best performance of the URC value among all these conventional models, including the MEL score, CTP class, and the next stages. And then we look inside among all these collagen parameters, including the collagen 10 based and also the nodule density based models. QCP has the best performance also. And finally, we use these models to calculate the survival probability. And we found that based on the KM curves, the QCP model can discriminate the low risk versus the high risk patients earlier and more accurate than the other conventional models, including the MEL, CTP, and the next stages. And then based on the multivariable Cox analysis, QCP model has the most powerful impact on the final outcome of these ADC patients. Based on this study, from this data, we can derive some major points. Histologic evaluation is not routine in risk stratification of ADC patients. The clinical relevance of histologic fibrosis and its prognosis value accordingly remain undetermined. Meanwhile, beyond cirrhosis, remodeling of cirrhosis takes many forms, not fully address the current critical histological criteria. Therefore, a quantitative tool such as the QCP we developed is optimal when comprehensively evaluating the clinical relevance of histologic fibrosis in ADCs. We found QCP can reliably describe histologic fibrosis and thus can be used in assessments of ADC patients if you have the liver biopsy samples. Because QCP feasibly characterized the histologic distinctions among etiologies and also QCP clearly replicate in the next stages to discriminate the different stages. Interestingly, HPG levels has no independent associations with CPA, SPA, nodule density as reported in previous reports, mostly about compensated cirrhosis. Neither did it show any difference between the ADC patients with or without 90 days mortality. That's very interesting and the data needs further validation. We also find QCP can be a valuable addition to the prognosis assessment of liver biopsy findings in ADC patients because first, it showed concordant associations with the next stage and MEL, that is a kind of independent association. And more importantly, it showed better performance on conventional indexes in predicting the 90 days mortality without liver transplantation. So overall, data on performance of QCP indicates histologic assessment of liver fibrosis as being of prognostic value. Our study also has some limitations. First, it is a retrospect study analysis of single center biopsy cohorts. We didn't compare the values, the predict values of QCP with that of the other novel indexes in ADC, such as the CLIF-C score, because introduced in 2013, and we have some patients, we didn't have the data of the CLIF-C score. And we considered only fibrosis data, but not activity data in our histologic assessment. And the liver disease in our cohort was of various etiology, so the particular predictive values for individual etiologies remains inconclusive. Ladies and gentlemen, now I would like to summarize our data. This study involving a large cohort of ADC patients demonstrates an important potential for quantitative fibrosis pattern in histologic pathology assessment or severity of liver disease, and in correlated manner in clinical pathologic assessment of likelihood of short-term survival. External validation of these findings and etiology-based investigations are needed to evaluate further the prognosis performance of QCP studies in improving accuracy of ADC management. Thank you very much for your attention.
Very excellent talk. So any question from the floor? Microphone.
天的那个终点事件，就它开始的这个阶段是个代偿期的吗？还是有A-on-C 这种情况？
谢谢尤教授的问题。我们做的所有的队列都是时代场的 decompensated sources。谢谢 ，Thank you。
是这个甘川是他以前的是吧？在 decomp 之前的。
这个甘川是他入院的时候做 HPG 的时候穿的。
非常有意思啊，王教授，这个我看到这个 ARC 比 mild 还更好，对，这有点出乎我的意料，就是到目前为止，我们全世界公认的 predict 它的这个 outcome 应该是 mild， 目前是大家公认最好，但是我看你这个 ARC 比 mild 还要好很多，所以我想听听你对这两个的这个评价。
孙教授的问题问得非常好。我们已经碰到很多次 reviewer 在提这个问题啊。mild 的话呢，如果是只做一个 cross section 的话，可能它的预测能力未必特别好，因为它是一个 biochemical based 的一个 the algorithm。but 如果你做一个纵向的 mild 的看的话，也许它的 performance 会再好一点。但是始终如果这个病人你治疗的话，他的那些指标可能会好一点，可能陈教授更专家。那么为什么这个 histologic fibrosis 还不错呢？是因为我们的理解是因为它是一个静态的一个过程，它就是你病人来了以后不管他之前有没有被处理过。如果这个肝穿有可能做的话医生正常的 practice 的 routine 的情况下给他做了以后，那么肝穿里面的这个变化不会很快就是 fibrosis 在那里是 statistic 一个 level，所以我们就 claim 觉得这个情况可能会帮助扩大这个治疗窗如果说他可以做，你又有这个条件给他做，然后看一下，也许比那个你观察3天或者7天的 mild 可能预测的能力要强一点但是这个病人始终是比较重，非常重的病人所以这个队列是非常的这个珍贵
我的问题跟尤教授是蛮像的，就是实际上我们在临床上这种时代场肝硬化，其实我们不太去第一个做肝活检是个非常困难的事情，因为 LBS 可能挺厉害的。第二个呢，其实我们在说在预后的时候，其实我也关心这个预后。其实预后的时候，往往其实除了肝细胞的这个量之外，就肝细胞的功能之外，其实门脉高压本身也非常重要。其实我们的病人会出血，然后会感染嘛，所以它影响因素很多。所以我就说这个时候在关心，就是如果短期预后跟它的联系，估计不是个非常。应该不是个，就是我们要临床大夫看这事，可能不是觉得特别那个。我倒是觉得可以将来看一下什么呢？如果他的如果肝组织里面，就是说肝脏里面的那个组织，就是叫纤维化成分多了，细胞成分少，肝细胞的成分少了，对这个病人的预后可能再长一点。比如说看半年、看1年，因为我们知道有些病人他会慢慢好起来嘛。如果肝脏里面的这个我们的 CTP 如果是越分越高，甲状腺纤维化越多，那意味着它的实质细胞越少。可能看半年、看1年的时候，是不是说这个预后可能会更加的重要？ 我这是我的想法，因为感觉上应该我们看28天、90天的时候，其实我们自己觉得，门脉高压本身非常重要，门脉高压本身非常重要。我提个建议啊。
好，谢谢。这个队列的病人跟那个陈主任，谢谢陈主任的问题。跟临床上的完整，它不是一个非常有 representative 的这个 cohort，因为它是一个 biopsy cohort，首先啊，所以呢，然后这个所有的病人呢，我们选的都是 cirrhosis 的病人，而且呢，你看它大部分都是 LANAC 4C，它是那个 advanced cirrhosis 的这个阶段，那么我们有 follow up 的 data 的这些病人呢，他们也是有一半以上是 ALD 的差不多，所以这些病人他的mortality 的 risk 就非常的高啊。如果是我们把它再细分一下 ，ALD 的可能都快到70%了，差不多。所以它是这个情况。然后呢，在我们这个组里面，那 HPG 的这个 data 也非常有意思，但是我觉得也可以解释啊。也许也可以解释，当然我们都不知道是确切的原因是什么。因为首先 HPG 呢这个监测呢，在这个 institute 其实是非常的 standardized 啊，可以说是亚洲可能是数一数二的比较好的一个。HPG 本身它的变化程度挺大的，它是非常 dynamic 的。这个测量这些东西。那么在这个队列里面，可能几乎所有的病人 HPG 它都已经到一个阶段了。In advanced cirrhosis 这个背景下，它的 HPG 已经到一个阶段了。那么它的在我们这个队列里面，既在那个分辨死亡不死9天死亡不死亡那边没有效果，而且呢，它也刚才要跟你秀那个 interesting 那个 point。他在跟那个如果用 compensated cirrhosis 的病人之前跟那个 CPA 那些有关，在这里也是没有关系了。很好玩，那个具体的 data 因为特别多。HPG 我们发现它跟 sinusoidal 的那边有一些 fibrosis 可能有一些关系。那么我们在想那个它是不是还是跟那个肝窦那边堵塞的情况那些有一定的联系 ，independent association。但是呢，可能是因为队列啊，这个队列都是很重的 HPG， 所以它的预测能力就不突出了。目前我们就是想，大概就是这个情况，解释啊。
好，谢谢王教授的精彩报告。下一个报告，这个印度它是录好像过来的还是 online 的？它是连线的吗？哦，连线 OK。
等1小时就完。
就是把下一个讲者 ，OK 了吗？如果不行，我们就让下一个讲者先讲。好 ，OK， 好，好，网络有点问题啊，那我们就下面先有请我们最后一位讲者，来自于南方医院的樊荣教授来给我们做报告。他报告题目是肝细胞癌的预测模型和 MAP 评分。
不是视频，是换的。
是哪一个文件？共享一下。
Good afternoon, ladies and gentlemen, dear Chairman. I'm Rong Fan from Nanfang Hospital, Southern Medical University. And it is my great honor to show my presentation on behalf of our research group entitled A Novel Pan-Etiology Pan-Ethnicity Hepatocellular Carcinoma Prediction Model called a MAP score. As we all know that the hepatocellular carcinoma is the sixth most common cancer and the second leading cause of cancer death worldwide. And the incidence rates of HCC or liver cancer vary widely among different geographic regions, and the highest in the East Asia. And the success of treatment for HCC largely depends on the stage when it was diagnosed. For the patient who was diagnosed at the early stage, the average survival time was more than 5 years. However, for the patient with advanced HCC, the average survival time is less than 1 year. So the effective and successful HCC surveillance program could offer early diagnosis and improve the long-term prognosis. The key is to have a simple and accurate tool to identify patients with different HCC risk and then individualize the HCC surveillance. And the HBV and HCV infection are the leading cause of HCC development. Over the past few decades, a number of HCC risk scores have been developed for kinds of chronic hepatitis, and especially most of the scores are for hepatitis B patients. This table summarizes the part of existing HCC risk score for hepatitis B patients. However, most of these risk scores assign heavy weighting to etiology factors such as the viral factors and only performed satisfactorily among population with specific etiologies or in the ethnicities. This limitation limited the widespread promotion and application worldwide in the current era of sustained viral suppression or clearance by using very effective antiviral drugs. Therefore, we conduct this study aiming to develop and validate a novel, accurate, globally applicable risk score for predicting HCC development through international cohort collaboration. This international cohort collaboration involved 11 prospective observational cohorts or randomized controlled trials conducted in 29 countries on 5 continents. These 11 cohorts include 3 CHB Asian cohorts, 2 CHB Caucasian cohorts, 2 HCV cohorts, and 1 non-viral hepatitis cohort, among which the CHB cohort is an antiviral-treated CHB observational cohort conducted in 15 centers in China. The REALM cohort is a BMS-sponsored randomized controlled trial in 2006. In this study, the integral-treated patients from the 50 centers in China were enrolled in the analysis. And the page B cohort is a European CHB observational cohort conducted in 10 centers in Europe. Besides, we also have 4 Gilead-sponsored global randomized controlled trial for TAF and tenofovir. And for the HCV cohorts, all of them were interferon-treated or DA-treated patients, and among which the HCV cohort from the United Kingdom and Gilead are all cirrhosis patients. We also have a small sample size of non-viral hepatitis cohort from Japan, and most of them are contributed to the NAFLD. So totally, there are 17,374 patients with different etiologies and ethnicities we enrolled in the analysis. In this study, the diagnosis of the cirrhosis and HCC were based on standard histological and or compatible radiological findings. The criteria of cirrhosis and HCC were a little different across the different cohorts. All the patients underwent the evaluation at least every 6 months. In this study, the Cox regression models were used to estimate the effects of various variables on the risk of HCC development and to develop the HCC prediction model. Syntax and calibration plots were used to evaluate the discrimination and calibration of the model, respectively. The Excel plots were used to generate the 2 optimal cutoff values to separate the patient into low, medium, and high risk group. We also used sensitivity, specificity, PPV, and NPV to estimate for the 2 optimal cutoff values of the risk model. And this table shows the clinical characteristics of the patient enrolled in this study. We can see then, besides the 2 cirrhotic cohorts from the United Kingdom and Gilead, the percentage of cirrhosis patients in the other cohorts ranged from 11% to 27%. And after a median of 3 to 9 years of follow-up, a total of 631 HCC patients were developed HCC. Besides, we also calculated the albumin-bilirubin score for each patient. Albumin-bilirubin abbreviated to ALBI, and is a simple index reflecting the underlying liver function calculated by the albumin and the total bilirubin levels, which was originally developed to predict the prognosis for HCC patients in an international setting. We take the centers with large sample size in the STC cohort as the training cohort to develop the HCC risk score. And the other centers in STC cohort, the other HBV cohort, HCV cohort, and non-viral hepatitis cohort as the validation cohort for the external validation. By using the univariable Cox regression analysis, it is found that the cirrhosis, E antigen, quantitative surface antigen, liver stiffness measurements, age, sex, ALBI score, and the platelets were associated with the HCC development within the 5 years. Considering that the cirrhosis diagnosis is relatively subjective in the clinical practice, the LSM test is not easily accessible in the most primary care settings, and the E antigen, surface antigen levels were violated parameters and could be influenced by the initiation or the withdrawal of antiviral treatment. So we confine our risk score to the last 4 parameters, that is age, sex, ALBI score, and platelet. Then a risk score known as the age, male, ALBI, platelet score, abbreviated to a MAP score, was devised by using above 4 variables weighted by the regression coefficient in the Cox multivariable model, and then the score range was standardized to 1 to 100. And the text box at the bottom shows the formula of the MAP score. The index of the MAP score was 0.82 in among overall population, and it was not substantially improved when the cirrhosis or LSM were included in the model. The index was both above 0.8 among patients with or without negative HBV DNA level, and where in the subgroup of patients with or without cirrhosis, this index was 0.74 and 0.75 respectively. The two optimal cut values, that is 50 and 60, were used to separate the training cohort into low, medium, and high risk group. We can see from the left table that around 60% patients were assigned to the low risk group with the 5-year cumulative incidence of HCC of 0.8%. In contrast, in the high risk group, the corresponding rate were 20%, which was 27 times of that in the low risk group. We also conducted the external validation of the MAP score in the other 10 validation cohorts. We can see that the index value in the other validation cohort was ranged from 0.82 to 0.87. Meaning that the MAP score was performed wonderful, not only in the Asian and Caucasian HB patients, but also in the HCV and non-viral hepatitis patients. And within the cirrhosis subgroup of patients, the index value was ranged from 0.6 to 0.83. The KM curves also showed equally good discrimination among the 3 risk groups in the validation cohorts. In these finger panels, we can see that the calibration performance of the MAP score was also performed wonderful in the validation cohorts. The cut value of 50 was associated with the 85 to 100% of sensitivity and an NPV of 99 to 100%. And the cut value of 60 resulted in a specificity of 56 to 95% and the PPV of 6 to 15%. We also compared the predictive performance of a MAP score for the HCC development with the other existing HBV-related HCC risk scores, including CHCC, SSMHCC, MHB, PHB, and MHB. We can see that the MAP score performed better or trend better, performed significant or trend better than the other existing HBV-related HCC risk scores, known both in the Asian and Caucasian patients. Our study also has some limitations. Firstly, the patient was recruited from tertiary hospitals and was especially linked to active liver disease before treatment. And it is likely that more patients would belong to the low-risk group in the primary care setting, and the NPV value would be further increased. Secondly, the PPV value of the MAP score at the cap value of 60 was not optimal. So next, we plan to combine the MAP score with the other biomarkers, such as the proteins or microbiotas, to further increase the PPV. Thirdly, the discrimination ability of the MAP score was suboptimal in the case of cirrhotic patients. This is also a common situation for the other existing HBV-related HCC risk scores. One of the possible reasons is that the cirrhosis diagnosis is not relatively accurate, especially in the root clinical practice. And finally, the formula for the MAP score is relatively complex. However, the parameters involved in the MAP score is very common, and we can calculate a MAP score by using the mobile app or the web-based calculator rapidly. in the current high-tech era. In the future, we plan to merge the MAP score into the liver function test panels or the hospital medical systems to further promote its application and guide patient management in the clinical practice. So in conclusion, the MAP score is the first score to facilitate the accurate, reliable, and simple to use prediction of the risk of HCC development, irrespective of etiology and ethnicity. This objective score is based on 5 very common parameters without the inclusion of etiological factors. Patients with a MAP score less than 50, accounting for 45% of our population, have the HCC incidence of less than 0.2% per year, meaning that around half of patients could avoid an intensive HCC surveillance by using a MAP score, which could save huge medical resources. And we believe then this score will be a useful tool for improving early HCC detection that leads to the high survival. And this study result has been published in the Journal of Hepatology. And we would like to thank our collaborators and our other investigators. Thank you for your attention.
好，谢谢樊荣的报告，看看。 好，齐教授。
我就中文问了啊，方便讲，就是非常好啊，这个研究发在不论在队列或者说设计上还有很多该改的问题，那毕竟发到 journal。那我这边有2个问题，一个是因为我们预测 HCC risk 它肯定是一个非常长时间的一个过程，那 AMAP 现在我们应该只是做了一个 baseline 的一个预测，不然在动态 dynamic 的无论是 HCC， 因为这里面其实。 我觉得叫 pan etiology， 其实它只有一个日本的一个中心的队列是非病毒性的，对吧？我觉得 pan etiology 可能，我们其实是病毒 dominant 一个 cohort。那对于 HCV、SVR 或者 HBV 抑制的，我们有没有做个动态的看 AMAP score 是不是一直是适用做这样的分析？
谢谢齐教授的问题啊，这是一个非常好的问题，也是之前 review 有提到过的。那么其实我们这个队列相对是一个比较，就是说各形各色的一个队列吧。那包括 SearchB 还有 Realm 还有 Gilead 的这些研究呢，它涵盖了各种各样的就是慢性肝病的病人，他可能接受了不同时间的这个一个治疗，或者是就是说他的一个应答的情况都是有所不同的。而这种各形各色的这种特征呢，就提示我们可能对于不同的治疗时长它代表的这些实验室的检测结果。 进而计算出来的 MAP score 都可以很好的预测它这个 HCC 的发生。
我觉得这个队列可以接下来 polish 很多 data， 我觉得可以把单独就 HCV 或者 HBV 拎出来。我们在做 MAP Baveno 现在最大的一个缺陷就是它也是 baseline 一次性的预测。我们现在有一篇文章正在投，我们是动态 dynamic 的 Baveno， 因为这个病人你需要 follow up 很长时间，它时间能够出 HCV 也是。
对，
我觉得可以单把 HCV 或者 HBV 列出来，看 AMAP dynamic 的一个价值。那最后一个问题就是关于 AMAP 的应用，因为我们现在其实你一个表已经很多 risk score 了，但是至少在临床实践当中，其实很多医院是不用这个 risk score 的。所以我很想知道你们的一些经验，就是我们说 OK 放到 APP 说的都很容易，但是真正推起来实际上还是有很大难度的，特别是在别人的医院，在自己的医院总好推，在别人的医院怎么推？我不知道您这个有什么计划？
确实，这个是推广应用，也确实是这个 MAP score， 包括也其他的一些风险预测模型所遇到的一个问题。所以我们接下来是计划，首先是通过医院的这些医疗的检验系统，先把这些病人通过他既往的检测来筛一遍，看一看这些病人的一个 AMAP 的一个分布情况。那么继而我们针对这种高风险的人群，然后再进行一个相应的开展相关的一些包括普及啊，以及开展相关的一些研究。
我觉得这个我们可以考虑来合作，因为我们现在推 CHESS criteria 嘛，就是所有在推的时候，它就不是一个单一科室的事儿，它要跟信息科去打交道。
对，
所以这需要整个医院领导层面的介入，才能把这个评分很好推。我觉得可以很多 MAP score 也好 ，CHESS criteria 也好，我觉得很多可以一块来推。好，谢谢。
好，谢谢。
看看如果没有其他的问题，我们就再次感谢樊荣教授啊，感谢他的精彩报告。So our last speaker from India, So Dr. Bihari, can you hear me? Hello?
Yeah, I can hear you. Hello, am I audible?
Okay. Let me introduce you. Dr. Bihari is from the Department of Pathology, Institute of Liver and Biliary Science from India. And his talk is the bone marrow dysfunction in cirrhosis. So now, Dr. Bihari.
Yes.
Hello? Yeah, you can start.
Yes, am I audible? Okay, thank you so much, introduction, chairpersons. So I hope I'm audible very well. Can you hear me?
Yeah, we can hear
Hello?
you, but you can share your screen and move your slides. Next.
Okay, so topic is bone marrow dysfunction and cirrhosis. And just a minute. So the outline of this presentation would be a little bit of introduction and then what alterations of the bone marrow can occur in cirrhotic patients. Now, as we all know that the bone marrow stem cells and liver disease has been explored in various studies, both in the experimental as well as in the clinical studies, where the bone marrow stem cell mobilization has been found to be effective in the treatment of cirrhotic patients and alleviating the complications as well as the patient survival. Now, we in our study in Liver International, we also found that the parenchymal necrosis after the growth factor therapy, it improves. Here you can see the inflammation and it decreases, as well as the little bit of fibrosis also decreases here. The CD34 cell, they increases in the liver parenchyma. The macrophages, that is the inflammation resolving macrophages, they also increase in case of GCSF treated patients. The alpha SMA amount decrease, the activity of stellate cells, and the Ki67 index increases in case of GCSF treatment. If you look at the milieu, you can see that the growth factors as well as the cytokines, they increases in the those growth factors and cytokines which help in the liver regeneration, they increase after the treatment. But if you see the functional assessment means what we did in this study, that we analyze various coagulation factor which are synthesized by the liver. So we assess those coagulation factor, including the protein C, S, factor 7, and others. And we noted that there was no significant increase, or there was no functional improvement after the GCSF treatment. So coming into the next part, that is the dysfunction in the bone marrow in cirrhotic patients. We all know that the growth factor mobilized bone marrow cell therapy or autologous bone marrow can improve the liver functions and survival, both in decompensated cirrhosis as well as in the acute and chronic liver failure. But the response is heterogeneous and not all patients respond well to this treatment. And we also have aware that the cirrhosis is a state of chronically altered metabolic, inflammatory, and circulatory milieu. And what this milieu can create, it actually can damage the stem cell component of the bone marrow by the process of inflamed aging and various stress factors. Now, in this study, what we identified that we did the markers for the bone marrow stem cells, the mesenchymal stem cell for nestin, and the Schwann cells and the neural fibers. These four parts, they encompasses the bone marrow niche or stem cell niche, especially in the peritrabecular area. So we found that all components of the bone marrow hematopoietic niche, they significantly decreases as the liver disease progresses to the MELD more than 26, or in case of child C. Now, if we look at the sinusoidal niche is apart from the previous we discussed about, that is the peritrabecular niche. Here we can see the sinusoidal niche, and the component of sinusoidal niche also decreases with the advancement of cirrhosis. Whereas this these sinusoidal niche, they also show the vascular transformation. So there is a more of neovascularization and fibrosis in case of cirrhotic patients. Now, what could be the reason? The reason could be again the same the cytotoxic milieu, that maybe because of IL-1 beta, interferon gamma, and TNF alpha, they are significantly increased in cirrhotic patients. So that can create a damage in the stem cell niche. Also, the growth factors which are required for the sustenance of this stem cell niche, they also decreases with the advancement of cirrhosis, including the oncostatin M, the stem cell factor, and the STF. So these growth factors are required for the sustenance of the stem cell component, and they decreases in the advancement of cirrhosis. On the clinical aspect, the lowering of the stem cells, what they cause is the lower hemoglobin and the low platelet count. If the baseline CD34 or stem cell component is low in patients, they have more chances of sepsis. And even after the transplant, the graft dysfunction, that is the modified early graft dysfunction, allograft dysfunction, is more common where the stem cell components are less at the baseline. Further, we identified that those patients who were treated with the GCSF, those who do not respond to this therapy, they have lower baseline CD34 or stem cell count, both in the IHC as well as on the FACS analysis. So if the bone marrow hematopoietic niche at baseline is low or the reservoir is severely compromised, then these patients will not respond to GCSF treatment. Not only the component are decreased, but they also show the alteration in terms of that they have more expression of the PU1, that is the pro-inflammatory marker, that is the myeloproliferative kind of lesion. So these two transcription factor, GATA1 and CEBP, they causes the maturation of erythromegakaryopoietic cells. These two transcription factor, they decreases in the advancement of cirrhosis, whereas the PU1 that lead to myeloid proliferation, it increases. So at both level, quantity as well as quality, both are altered in case of cirrhosis. Similarly, the marker which is the receptor which is used for GCSF therapy, if you give GCSF, then it will act through the CSF3R receptor. And if we analyze the CSF3 receptor in the stem cells, it also decreases with the advancement of cirrhosis. And this is at the transcription level, and this is at the translational level. On clinical point of view, those patients who do not respond to GCSF therapy, they have lower level of GCSF-R, that is the GCSF3R receptor. So it is low. And also those patients who have refractory neutropenia, those patients who do not recover even after GCSF treatment, they have the receptor level down. So in advanced cirrhosis, the receptor is also down, the cells are down, and they are qualitatively abnormal. Coming to the next part, that is the mesenchymal stem cell. As you all know, that it decreases the inflammation, it helps in the liver regeneration, it reduces the hepatocyte apoptosis, and it decreases the stem cell, stellate cell activation, and decreases the deposition of collagen. But in case of cirrhosis, these mesenchymal stem cell, they show more of the senescent changes. That means there is a qualitative alteration of the mesenchymal stem cells. So here you can see the higher expression of P21 and CDKN1. They also indicate that they are not well in case of cirrhotic patients. In this study, we identified that the colony-forming performance of the mesenchymal stem cell, it is low in cirrhotic patients. They have more adipogenic properties rather than the osteocyte or osteoid differentiation. Here, this is the control and cirrhotic, and this osterix is deposited in the bone by the mesenchymal stem cells. So it is low in case of cirrhotic patients, and perilipin, that is the adipocyte differentiation of the mesenchymal cells, it increases. Also, in advanced cirrhotic patients, the osteoclast proliferation and their maturation is more pronounced in case of cirrhosis. All in all, in the mesenchymal stem cell in cirrhotic patients, they have a decreased osteogenic property, and they have more adipogenic property. Alongside this, there is a more chances of osteoclastogenesis. That's why in cirrhotic patients, they have low bone index or bone mineral deposition and have a chances of osteoporosis. Moreover, the bone marrow precursor cells also show the dyspoiesis. That means they have the maturation defect. Here you can see these are the erythroid precursors. They have the maturation defect, means the nucleus is fragmented, karyodexis, they are multinucleated, binucleated, and there is a nuclear bridging. So these cirrhotic patients, some of the cirrhotic patients who have severe anemia, they also show the maturation defect in the erythroid cells. Moreover, in case of cirrhotic patients, those who treated with the antimicrobials, they have hypocellular marrow in comparison to those who are not, those who have not received the antimicrobial treatment. And mostly the beta-lactam and the quinolones, they have more effect on the bone marrow. So this is the summary that the intact bone marrow is critical for liver regeneration, and the bone marrow niche, including the various cells, they have alterations in cirrhotic patients, and that's why we have a limited success of bone marrow based regenerative therapy in cirrhotic patients. And we can use bone marrow niche cells or their surrogate markers to classify those patients who can be potentially benefited by the regenerative therapy treatment. Thank you. Hello. Hello.
Hello, Dr. Bihari. Can you hear me?
Yes, yes.
Okay.
Yeah, I can hear you.
Okay, thanks for your excellent talk. Finally, I think we have catched what you have told us. So thanks for you.
Yes.
And welcome you to Guangzhou.
Thank you.
Okay, thank you.
Thank you. Thank you. Thank you.
So I would like to introduce Professor Jia to moderate the next session. Yeah.
Thank you. Now we move to the next session without tea break, but you can have tea if you like. The first speaker is Dr. Liu. Today, his topic is pathological quantitative diagnosis of NASH. Without further ado, now I'd like to invite Dr. Liu to give a talk. Is it online or online? Okay.
贾教授能听到我说话吗？ Thank you, Professor Jia's introduction. Good afternoon, ladies and gentlemen. I'm Feng Liu from Peking University People's Hospital. I'm honored to introduce the presentation, Pathological Quantitative Diagnosis of NASH. Sorry. Sorry. The prevalence of NAFLD is estimated about 25% all over the world. And so NAFLD is a major cause of the chronic liver disease worldwide. NASH is the secondly the hepatocellular carcinoma leading to liver transplantation in the US. And therefore, there are currently no approved pharmacological therapies for NASH, but the clinical trial design for NASH therapies are evolving rapidly. Oh, sorry. At present, liver biopsy is considered the current gold standard for diagnosing NASH and fibrosis. And histologic evaluation in determining therapeutic efficiency, particularly in phase 2B and 3 studies. When we evaluate histology in NAFLD patients, we should know the main patterns. It includes steatosis, hepatocellular injury, such as ballooning, inflammation, and fibrosis. There are currently a accepted scoring system for grade and stage NASH in clinical trial, include SAF and NASH-CRN scoring system. And NASH-CRN system are often used in clinical trial. But there are some limitations of liver histological assessment. Let's see the table. We can see the kappa value is low, especially for inflammation and ballooning. We can see they are low. So it suggests inter-observer variability may hamper histological assessment. And a recent research reported when evaluate NASH resolution, and we can see the kappa value is low. So kappa were poor for the evaluate NASH is resolution and the improvement. Therefore, the current scoring system mainly used in clinical trials is not suitable for the evaluation of the dynamic change of the disease. So recently, hepatologists and pathologists may suggest it's time to apply quantification in liver biopsy as in endpoints. And digital pathology may provide a possibility for objective and accurate evaluation of pathology. From this figure, we can see the digital pathology may be based on a staying approach such as CPA and a stay-free approach as SATPEI, EF, and other staying and image analysis. In this presentation, I would focus on these two approaches. Let's see the stained slide. Because the degree of liver fibrosis is the most important diagnostic and prognostic assessment in chronic liver disease, quantification of liver collagen we first development by digital image analysis. This is cirrhosis red, the stay in collagen, and the green in colors was identified by digital image analysis. From this figure, we can see the CPA values increased is worse in shock stage. For the steatosis research, most research focus on the wild regions. And in these studies, they could exclude portal veins and bile ducts, and we can see the green colors. They could identify the microsteatosis with high pre-excitation, more than 82%. And for the inflammation and ballooning, it's very difficult. So there are few researchers on it. This is the first reported shown and hepatocyte ballooning. It suggests it is feasible in digital image of liver biopsy. And this comes from a recent report last month, and they use HE image for identify steatosis. Steatosis is green colors, and the blue color suggests ballooning cells, and the purple color suggests the inflammation. They also use cirrhosis red for identify fibrosis, and we can see that they have a closer relationship with the grade and fibrosis stage increased. And so they develop a fully automated software for quantification, steatosis, inflammation, ballooning, and fibrosis. And in the last year, APASL Gilead gave the similar research. And the difference is they use trachrome image for fibrosis. Also, they combined with alpha SMA results. In this year, the ESO meeting also have research on evaluation fibrosis, steatosis, inflammation, and iron overload. And we can see they use immunohistochemistry with adenoporphyrin for fat and with CD4 for inflammation. Now, with summary on the stained slide, we can see for identify fibrosis, they may use cirrhosis red, trachrome, and HCC with the alpha SMA. And for steatosis, inflammation, ballooning, most use HE stain. And for steatosis, may use adipoline, and for inflammation, may use CD4. And Gilead and Folland, the group, they have the fully automated quantification for these four pathological factors. But due to variability in staining, these techniques might suffer from poor reproducibility. So let's move to the unstained slide. Professor Wang had introduced the SHG in the previous report. We can see the SHG TPEF is based on a stain-free approach. It could obviate the variability related to the staining process. First, let's see the fibrosis evaluation. And this green in colors is collagen identified by SHG. And we divide the collagen into central vein collagen, portal tract collagen, and perisinusoidal collagen. Also, there is total collagen was separated into aggregated collagen and distributed collagen. And also we consider morphological factors such as orientation, length, wells, parameters, and wells. All these combines about 100 factors of collagen. Then in our primary research, we found six distinct parameters were selected from adult and pediatric NAFLD. We could see they have a good relationship with the fibrosis stage, and the AUOC values is high. It suggests that SHG analysis could accurately reproduce NASH cell end staging. And also, we can find SHG analysis could reveal difference between adult and pediatric collagen. We can, from this figure, we can see for central V collagen, the aggregated and distributed collagen have a different model. We can see from one stage to stage 2, the aggregated decreased and this distributed collagen increased. Professor Wang, they have a good research on hepatic fibrosis in NAFLD based on quantitation of fibrosis related parameters. They selected, we can see these 4 parameters have a good were independently associated with fibrosis stage and were used to model fibrosis along a continuous linear scale. And furthermore, they found 3 parameter and no longer strain demonstrated consistent and robust diagnostic performance across fibrosis stage. I think the important is they found the 2 parameters at baseline had a high risk of developing hepatocellular carcinoma and cirrhotic complications during follow-up. As we know, it's difficult to differentiate stage 1 from stage 2. So Professor Liao, they established an improved fibrosis is algorithm for the screening enrollment into NASH clinical trial was established, and I had introduced the collagens. They divide into protractor, southern collagen, and in this new definition, they give the periportal collagen. So 26 parameters constitute an oval sub algorithm that could accurately stratify F1 and F2 cases. For the fibrosis evaluate, we know it's important. So in the future, May is able to predict the progression or regression of this disease. And Professor used they established the Beijing classification, and this classification may give some idea on the NASH, the progression and regression. And Professor Wang also introduced the QFAB could predict mortality and prognostic value. For steatosis evaluation, and George, they gave the first study to use the SHG to could say they identify the as horse to find the steatosis, and they found the good relationship with histopathologist with automatic SHG assessment of hepatic steatosis with personal correlationship. So we suggest SHG could identify inflammation and ballooning. So we work together with Professor George and the group. We suggest a combined system, QFABs, quantitative fibrosis, inflammation, ballooning, steatosis. And I had introduced the fibrosis, and for the inflammation and ballooning, there are the same models, just like fibrosis. From this figure, we can see QFABs is comparable with the pathologist scoring. We can see for the QFABs and the steatosis, the R value is high, and it suggests the QFABs could accurately quantify NASH histologic assessment. Also, we can see the AUC-LC value is high for the QFABs inflammation, ballooning, and steatosis. So it must suggest the fact QFAPS is observer independent and reproducible assessment. So like as summary on the unstained slide, we can say a lot of research focused on the fibrosis, and Professor Wang had a good research to evaluate fibrosis, and they suggest the QFAPs have a prognostic significance. And George established evaluate steatosis, and we worked together with their group. We established a fully automated quantification of the NASH. So summary, and liver biopsy is crucial in the diagnosis and in diagnostic activity and fibrosis. And quantitative digital pathology may provide a possibility for objective and accurate evaluation for pathology, and fully automated quantification based on a machine learning may give a more objective interpretation of disease activity and determine response to therapeutic agents in practice and clinical trials. As we know, from this year, the method was mentioned and recently APASL present the practical guideline for the diagnosis and managing of method. We can say in this practice guideline, fibrosis is still the main determining of the other complication of method, and liver biopsy is regarded as the reference standard. So we think whatever the method and method, the pathological quantitative diagnosis may be the future gold standard. And thank you for all my cooperation, and thank you for your attention.
Thank you, Dr. Liu, for your talk. We may have only one question raised. Some question or comment? Anyone? If there is. Professor Wang Yan, you are frequently quoted in her talk. You may give a brief comment on or question or comment on this.
Thank you, Professor Jia.
Thank you. Very nice talk, Prof. Liu, and thank you, Prof. Jia, for the chance for me to make some comments to this study. As we know that there's a lot of, recently there are a lot of applications regarding how to use the digital pathology to quantify the features in NASH fibrosis and in NASH biopsy. So compared to the other ones, for example, they use stains, normal HE stained liver biopsy specimens. Any strengths of in your study? Could you make some comments on it?
Sorry, Professor Wang, can you speak in Chinese? Sorry.
Question, just repeat the question. In Chinese.
Oh, okay.
Sorry.
Okay, no problem. 因为最近呢有一些报道啊，就是因为 NASH 的 histology 的诊断呢非常重要啊，所以刘教授、魏教授的这个研究非常的重要，也很重要的意义。因为这个领域非常重要呢，所以最近呢也有一些陆续的 digital pathology 方面的报道出来。那么最新的我看在那个 APT 上有一则研究是用了这个普通的 HE 染色的HE 染色的和还有这个马松染色的临床常用的片子做的这个也是同样的研究的目的的这些报道。 我不知道您有没有继续关注这方面的研究啊？您能不能评价一下，就是您的研究和最新的这些用临床常用的染色方法的这些样本的这些研究之间，各有什么优势和这个不足的地方？谢谢。
谢谢。抱歉，贾教授，我可以用中文回答吗？是这样，就是我知道汪燕教授和尤红教授、贾教授那边他们都做了，其实在这方面做了也很多的工作。然后对于这个，因为从我们的最早提出这个全定量分析是大概18年，我们在 ASRD 上进行了这个口头的汇报。然后后来陆续吉勒德他们也包括欧洲，我记得当时欧肝会好像也有一个 abstract， 当时但是我们没有找到他的，因为可能涉及商业机密，我们没有找到他那个具体的方法。他也提到他那个方法是全定量。我目前能查到的方法，除了这个 SHG 的方法吧，基本上都是这种用染色的方法。染色的方法用，我觉得我自己的感觉是用天狼星红，它可能这个染色对这个定量评估的干扰会相对的小一点，但是马松染色，我觉得这个可能会干扰对这个胶原的染色，我觉得这个有点不可靠。如果说是用染色的话，我还是建议用天狼星红。如果说是这个染色稳定的情况下的话，用这个全定量评估，包括吉利德和刚才就是我提到的那个，他们刚发那篇，就是9月份刚发那篇文章，用HE 和那个天狼星红来全定量，我觉得也是认可的。但是就是看他们的 HE 和天狼星红染色是不是稳定。另外，对于我们提到这个 SHG 这个方法呢，我们是提出来这个全定量。我们认为我们这个是可以避免的这个染色这个干扰的，但是我们也知道这个方法，包括汪然教授，您也在这方面做了很多研究，您也知道，起码它对胶原还是非常相对来说，现在 fibrosis 方面，就是胶原这个建立它是非常稳定的，而我们的结果也表明它对胶原和这个脂肪变是非常稳定的，但对于 ballooning 和 inflammation， 它可以看到我们这个数据也表明它的 R 值和 AUC 值都是相对比较低的。我们是看好这个方法的，但是我觉得我们还是需要更多的这个临床样本来验证。包括汪然教授也提到了，因为您那边有大量的样本，包括那个水访的一些样本，我觉得也需要在后期的，如果有更多的这个随着这个 NASH 的这个药的慢慢的一个前期的一个实验的一个上市的话，我们也可能也需要一个治疗前后的一些这个样本来进一步来看它的这个效果，我们也希望看到它的一个对 follow up 的这个效果。谢谢汪教授。
Okay, thank you for your talk, nice talk, and a very good discussion. Now I'm pleased to invite my co-worker, Professor Yu Hong. She's also my boss she's in charge of the research affairs in the hospital. She's very tough with me on this respect. So please welcome Professor Yu's topic is, I don't know the translation is correct. The quantitative measurement of regression of liver fibrosis or something like that. Seems the Chinese and English a little bit ambiguous. 它这个中英这个两个有歧义。
对对 ，regress 这个还不是回归哈，是那个逆转。Right. Thank you, Professor Jia. So today I'm reporting the regress or reverse of the liver fibrosis. Should we assess the quantity or the quantitative of to assess the septa or the collagen? Actually, Professor Wang Yan, Professor Liu Feng give us a good talk on how we evaluate the regress of the fibrosis. Conventionally, we do the semi-quantitative using E-shark, decrease higher than 1 stage. And we proposed with Professor Jia, the quality of the collagen, which is actually, we call it a quality of the septa. And the quantitative, which is the full quantitative, either CPA or SHG, is very, very helpful, particularly for clinical trials. And most importantly, actually we notice there are about 10 to 20%, particularly in viral hepatitis patients, even under the anti-HBV treatment, those patients may progress, which means those may become the decomposition or the HCC. What are the reasons for those? How we evaluate those? Is there any so-called point of no return? So I will discuss this in the next 15 minutes. We all know ESHAC decreased higher than one stage is we call it semi-quantitative. Actually, it is not fully semi-quantitative because stage 4 is much severe than 2 times of stage 2. To assess this in the Chinese patient, like 7 years ago, under the support of the national grants 5 years plan, that's we conducted the reverse study, optimized the treatment. Pre-treatment, we did the first biopsy, and after 1.5 years, we did a second biopsy in those antiquia-based therapy. When we assessed those, we found that there's not only ESHAC decrease, there are actually before treatment, those were wide, broad, loose, and the inflammatory receptor, which indicate the progress of the liver fibrosis. But after treatment, those septa started to be very thin, delicate, and splitted by the regenerated cell. We call it reverse of the septa. So some of the indeterminate between. So we set up this Beijing classification to assess this is not only how severe the patient is, but also what is the progress? Will it reverse or will it progress of the disease? And we know that's 2 patients before and after treatment. Those were the ESHAC 6, now ESHAC 6P to ESHAC 6, still 6, but 6R, which indicate the reverse. Then this 6P to 6R, and the LANAC 4C to 4A, LSM 35 to 10 kPa, which indicate the improve of the diseases. So how about the quantitative? As mentioned by 2 professors before, and we have those so-called high technology SHG, TPEF to assess the quantitative. I just want to show, compared to the ESHAC, decreased than 2 stage, there's no problem of like 5 or 6 to 4, and the ESHAC decreased higher than 1 stage, there's still slightly reverse decreasing of the ESHAC. Most importantly, that's among those ESHAC, no change, but we can identify those color indicate increase, in yellow or in red. Those color indicate decrease, which is in blue. Actually, they are mixed in those stable, ESHAC stable patients. And when we compare the heat map, so-called heat map, according to all those collagen parameters, we find those which was stable, was considered stable, no change of the liver fibrosis. Actually, about 40% of them similar to the regress, and another 10% of them similar to the progress, and only 20% among those so-called stable patients are real stable. So those was quantitative, particularly again for the clinical trials, when we try to compare before treatment, after treatment, that may help us to understand what is slightly, might be very moderate difference to continue these trials or just stop these trials. So it's for the research, but for the clinical big outcomes or events or called endpoints, we need more studies, we need longer following up to confirm those Beijing classification and PIR and also quantitative. We not only can do the fully quantitative of the collagen, also for the Beijing classification, actually it's the progressive septa, we can also do this quantitative. For this reverse septa, we can also identify those, and it indicates very well fits with the idea of the PIR. So actually today, most importantly, I want to go through this, why some of the patient progress and how to evaluate those. When we do the analysis, actually we do this ESHAC decrease than higher Then one stage is the dark green, and the light green is by PIR. That means actually by PIR, we can identify more patients, maybe sensitive to identify those reverse patients. But most importantly, we're not looking at the good patient, good response patient. We also look at those progress patient within in orange color and dark orange. Either the ESHAC 3, 4, or the cirrhosis patients. The fibrosis reverse is about 70% in our study, but there were 35 about actually 14% of the patient, either in this advanced fibrosis or the cirrhosis, they got progress. So the patient get worse and worse. What are those patients and how could we evaluate this? Actually, again, compared to the good patient I just showed before, there's actually the worst case. Those were the ESHAC 4 before treatment. Those are ESHAC 4, so 4P and 4P. So those was before treatment. This is the 1.5 year of treatment of the anti-HBV treatment. What happens to those patients? If I didn't say this is after treatment, maybe you said this is actually very similar case, the same case without the treatment. And compare those patients that we noticed, besides for the like alcohol, new de novo taking the alcohol, HBV DNA is the main problem. Now it's very commonly accepted, the low viremia. Among those patients, there are many of them have the low viremia, which is not detectable by the not sensitive methods, like only the average HBV DNA is between 20 to 200 IU, which is under the limitation of the non-sensitive methods of the PCR. And we can tell those progressive, which is the orange color, HBV DNA decreased at the first half year, but then keep stable or even a little bit higher during the treatment. So for those patients, when we did the in situ HBV RNA scope, we found those were the highly replicated HBV RNA, which means inside the liver. There are still HBV DNA replication, indicate this may lead to the progress of the disease, which actually remind us we should give the potent, even higher, stronger anti-HBV treatment. Now we are here. Actually, 7 years ago, we did this first, and then we did the second biopsy. Now we are here after 5 years of treatment. Here we got about 100 cases with 3 biopsies, with short term of the treatment and long term, 5 years of anti-HBV treatment. What happens to those patients? If we give the longer enough anti-HBV virus, will these patients be better? The answer is yes. Because here we saw this is the 1 patient before treatment, 1.5 year treatment, and 5 year treatment. We saw those patients with the ESHAC 6 progress 6P goes to the 5R reverse. So delicate septa, splitted septa, and then go to the ESHAC 3 regress. So those are very nice patients. After treatment were very exciting to see the results. The patient with cirrhosis starting to be non-cirrhosis, or maybe after longer treatment. This is very good. But we also saw those patients who is the ESHAC 5 progressive after 1.5 year, still ESHAC 5 progressive. After 5 years of treatment, among those, we still give the very strong anti-HBV medicine treatment, like entecavir-based treatment. And those, after 5 years, those patients seems like the HBV very well controlled and the inflammation is well controlled. But those with ESHAC 5 and the septa is still wide. There's no inflammation, but the septa is still there. So we call it silent cirrhosis, and the portal hypertension will be there. Whether those patients be, this is already 5 years of the treatment, whether the patient be better, we doubt. So those were might be the this like torted of the nodules or changes of the blood flow. Also, we saw those cases. Those were not before, and those were patient 1, 2, and 3. All of them are after 5 years. Those patients were started with the compensated cirrhosis. So before treatment, there's no biopsy. But after 5 years, we saw all those improvement of the liver function. We saw all those improvement of the any clinical markers. So we suggest the patient try to do the biopsy after 5 years of treatment. But those patients still, or like still nodules, white septa, nodules, inflammation, and there's actually, this one is a little bit better, but still there were white septa after 5 years of the treatment. Silent cirrhosis again. So it's this distorted structure, it's the collapse, so-called collapse of those nodules, and this will be portal hypertension. Those patients will have the esophagus varices, may have the progress of the decompositions, and with the poor outcome. So how we assess those patients, how we treat those patients, how we deal with those patients is still very important for the future. We need to pay attention to those patients because those who are really 10% of the patient, we do really to treat those. So here's my summary of the talk. Fibrosis, cirrhosis now can be proved. How we assess the regress. Semi-quantitative, ESHAC, still the gold standard, like the fully quantitative and the PIR Beijing classification, I'm glad is well used right now. And we use it actually to assess our own patient routine practice. And also there are 10%, 20% of HBV. HCV has a similar situation. So among those patients under treatment but still progress, actually those were the patient we need to treat, we need to pay attention. I would like to thank for our colleagues, and particularly there were colleagues here like to provide all those important clinical studies. Thank you.
Thank you, Dr. Yu, for your very clear presentation. Maybe we can have one question. Yes, please.
Always very nice talk from Prof. Yu, and very clear, very neat slides. I have a question because as you pointed out, we still have some patients even after SVR for the HBV and also HCV. So do you have any perspectives on the treatment to such patients, how to anti-fibrosis for this patient? Do you need particularly any invitation to their fibrosis, or we just keep watching them, monitor them? Yeah. Thank you.
Thank you. That's a great question. Actually, we find two risks in our study published recently in in CGH, Clinical Gastro and Hepo. Two reasons. First, there were about 3% with de novo alcohol intake, so that stopped the drink alcohol. Second is the low HBV DNA. So maybe we should change or we should add on to the stronger anti-HBV treatment like plus TDF or TAF. That is for the reasons we stopped those reasons. But for those silent, so-called silent cirrhosis, it seems we don't have any because those DNA was well controlled. So maybe we should add some like a beta blocker or a cavedolol to stop those portal hypertension. So those need to be understand actually, I think, what is the mechanism and then give the treatment.
Okay, thank you.
谢谢，谢谢。
Now, I'm pleased to invite Dr. Liu Li from the Nanfang Hospital, Southern Medical University. Today, the topic is exosome in liver disease, which is a very interesting and emerging field. Now, Dr. Liu, please.
桌面。
Thank you for Chairman Qi and Professor Ho and Professor Jia gave me the opportunity to introduce our work. My topic is extracellular vessels as a therapeutic tools in liver disease. 我觉得要不我讲清楚点，拿中文讲算了。
主席戚小龙主席在这儿。
那英文也行，我的幻灯基本上也都写在那个，但是我觉得如果能讲清楚点，还是拿中文讲。
有没有往外转播的那个？我们这一场。
因为我是做肿瘤的嘛，所以以前呢，大家就是这次还是精心准备了一下那个外泌体在肝病中的作用。因为呢，以前大家对于外泌体的印象呢，可能就是更多的是局限于它作为一个那个 biomarker， 然后用于诊断呐和其他的一些情况。所以这次我主要准备的呢，就是说它作为呢，就是在肝病治疗中的作用。那么在肝病治疗中呢，还是相对来讲还是比较新的一个领域的。那么外泌体呢，我们知道是什么样的情况呢？就是说细胞之间的一些那个 communication 是通过外泌体来发生的，它可以里边携载着一些蛋白啊，例如说生长因子啊，一些 RNA 啊，还有就是像 link RNA、microRNA 以及 circle RNA， 它都是可以的。那么细胞外的囊泡呢，也就是说就是一个 cellular vessels， 然后它是包括外泌体，就根据它直径的不一样呢，分为几种，一种呢叫做大的囊泡，一种是外泌体，还有一种是凋亡体。那么我们可以看外泌体呢，它分泌呢是有2种渠道的，一种呢它就是包括 ESCRT 依赖的渠道和一种呢是 ESCRT 不依赖的一个渠道，这是它产生的一个那个 biogenesis。另外呢，就是对于一个外泌体，它的优势呢就是说它有一个那个膜的结构，所以这使得呢它更容易进入到肝细胞里边，而且呢是更容易进入到脂肪细胞里边，这是跟其他的作为一个载体不一样的一个地方。那么对于肝脏来讲呢，我们也知道肝脏是人体最大的一个就是内分泌的一个器官，而且它里边的细胞呢也是非常多的，就包括巨噬细胞、内皮细胞，还有一些肝星状细胞、肝细胞等等，所以它细胞和细胞之间的一个 communication 会更多，所以外泌体呢在肝脏中的研究呢中也是最多的。那么从就是酒精肝来讲呢，我们可以看到它也是。酒精性肝病呢，它可以分泌很多外泌体，从而作用于肝细胞，作用于肝巨噬细胞，从而呢加重它的炎症。那么我这里边这个 table 呢也列举了，就是说一些外泌体所分泌的涉及到有哪些肝病，基本上我们所有的就是 liver disease 基本上是都涉及的，不管是 NASH、NAFLD、fibrosis 以及肝癌都是涉及到的。那么举个例子来讲呢，就是说，例如说这个酒精呢，它可以刺激肝细胞呢分泌很多外泌体，这些外泌体呢就可以包括很多 microRNA， 包括 micro122、micro192以及 micro30A 等等。这些呢，同时呢，它酒精呢又可以刺激到肝巨噬细胞，促进了肝巨噬细胞又分泌了很多大量的外泌体，所以这些外泌体呢，它们就可以呢。就是作用于呢，就是 naive 的这种就是单核细胞，使它呢就会有一个 M2 的一个就是转换，从而呢就是加重了它的炎症，使得它酒精肝的炎症呢是非常加重的。那么所以外泌体呢是参与了很广泛的一个肝脏的一个疾病的。那么就是说，除了就是肝脏就是外泌体作为肝脏的一个 biomarker 呢，那么目前在肝脏所有领域的研究中呢，它能够发挥治疗作用呢，主要是局限在4个方面。第一个呢，就是对于肝脏来讲呢，一个是干细胞所产生的一个就是外泌体；第二个呢，就是说外泌体的一个叫做就是改良的结构，也就 NV 的一个 vessels；还有一个呢，就是把它作为一个载体，就是EVs load with drugs siRNA microRNA， 就是说它作为一个囊泡。第4个呢，就是一些 compounds 有inhibition 来发挥这样作用。那么在肝脏疾病中呢，目前主要是这4个方面。那我们可以看第一个方面呢，也就是说干细胞所产生的外泌体。干细胞产生的外泌体呢，目前已经进入到1期的一个临床研究了。那么为什么它是非常好的一个 载体呢？那就是因为干细胞它所产生的麦粒体呢，它不需要过多的去 loading。那我们也知道，其他的细胞所产生的麦粒体，它的量是不多的，但是干细胞的产生的麦粒体呢，它是不需要再 loading 的。另外呢，一个就是说干细胞它所产生的麦粒体，研究发现它和干细胞的治疗作用是一样的。那我们也知道干细胞它有修复作用，然后有一些再生作用，那么它的麦粒体和它的那种干细胞的作用是等同的。并且呢，它没有就是干细胞所移植所产生的这些风险，所以呢，就是说目前在干细胞所产生的麦粒体的研究领域呢，大家认为呢，可能比干细胞的作用呢发挥的会更多一点。那么就是说，我们可以看到这种就是说干细胞呢，它所产生的有很多的一些细胞因子，以及呢麦粒体，还有就是说 microRNA。它们在各个领域呢都发挥了非常重要的作用。例如说，它在肝纤维化里边也发现了它可以促进呢，就是TGF beta 1的表达，也是参与到肝脏疾病的一些进展的。那么第二个呢，就是一个嵌合型的一个麦粒体的一个结构。那么这个为什么说呢？就为什么叫做改良的，也叫做 NV， 就是我们对于麦粒体呢叫细胞麦囊泡，我们是 EV。那么对于这个呢叫改良后的叫做 NV。它的作用就在于哪呢？它可以达到一定的量。那我们也知道，对于麦粒体和细胞麦囊泡，我们研究的最大的障碍就是它的量是非常少的。那么第二种方法呢，就是说它可以达到一个负极。那么它所产生的量是其他麦粒体就是天然所产生的量的100倍，所以呢，它就可以达到一定的量，然后达到一个就是一个肝脏疾病治疗的一个效果。而且呢，目前也有很多商业化的 NV 来进行一个，也已经有一些商业化的 NV， 并且呢，已经进入到了1期临床。那么举个例子来讲呢，有一个研究呢，它也就发现就是。原代的一个肝细胞呢，它所产生的这个麦粒体，就是经过负极之后呢，它可以显著的促进了肝脏的一个就是再生，以及呢就是修复受损的肝细胞，所以这个呢也是进入到1期临床了。那么第三个作用呢，就是对于就是 EV 来讲呢，就是作为一个载体，那么它可以载一些药物，可以载一些 siRNA， 可以载一些 link RNA， 它可以作为一个载体。因为它有一些天然的结构，所以它作为一个载体呢，会有一个它更多的一个优势。那么这个呢，就是说什么样的来源的麦粒体可以作为载体？那么来源呢是非常多的，我在底下也写了，包括就 DC 细胞，然后 MSC 细胞、巨噬细胞、红细胞，甚至一些就是牛奶因为牛奶里边也是有麦粒体的，所以这些呢产生的麦粒体呢都是可以作为载体。然后把一些药物或者是一些 siRNA 导进去，从而达到一个肿瘤治疗或者是肝脏疾病治疗的一个效果。那第四个呢，就是说一些那个抑制剂。我们也知道，就是麦粒体对于肝脏来讲呢，它是参与到肝脏的一些病理的一些过程。那么如果我们要阻断这些过程呢，也可以用一些抑制剂，从而呢达到一些治疗的一个效果。那么通常这种抑制剂呢是要进行一个 combination 的，就是说你单一的一个抑制是不行的，必须要一个多重的一个抑制。有一种抑制呢，就是抑制就是麦粒体的一个释放，也就是抑制它的一个穿梭。那例如说就是Y27、632这些药物基本上也都进入到1期临床了，它可以抑制麦粒体的释放，那么减少你细胞之间的一个 communication， 从而达到一个治疗的一个效果。那么另外一种渠道呢，就是抑制麦粒体的作用呢，那就是抑制脂质代谢，从而达到呢就是抑制你麦粒体生成的这样一个效果，从源头上阻止一些麦粒体的生成，从而呢达到一些治疗上的效果。那这个呢也是在肝脏疾病上已经开始应用了。那么在肿瘤中呢，还是用的是最多的，因为今天主要讲的肝脏，所以所举的例子大半都是肝脏。那么肿瘤中的作用呢是更多的，无论是说载一些化疗药物啊，还有一些载一些 siRNA 啊，还有说载一些靶向的，就是修饰后的一些麦粒体来载一些更多的能够靶向的这些药物，就是目前呢用的是更多的，而且呢他们也发现，即使对于耐药的表型，就 MDR 的一个phenotype 这种耐药的表型呢，也可以达到治疗的一个效果。那在我们每年的就是我们肿瘤的年会上 ，AACR 或 ASCO 啊，基本上每年现在麦粒体作为治疗的这种样的一些文章啊，或者是报道是越来越多了。 那么我们课题组呢，前期呢也是做了很多关于外泌体一个研究，其中呢我们就发现一个非常有意思的一个现象，我们就发现肝癌呢实际上它是处于各种 stress 的一个情况下的，无论是乏氧应激啊、ER stress 啊，还是 ROS， 那么肝脏呢它是经常处于一种 stress 的一个情况，那么这种 stress 的情况呢就会导致很多外泌体的一个释放，那么其中呢我们做了很多研究呢，我们就发现 MIR30A 呢。它在这种各种 stress 的情况下，它就会释放到血液中，然后从而呢从尿液中排出去，从而呢维持呢它在细胞内的一个低表达。那么MIR30A 的一个低表达呢，我们也看到是跟肿瘤的一个进展以及肿瘤的不良预后相关的。那么我们就证实MIR30A是通过肝脏细胞就是肝癌细胞排入到血，通过尿液排出，从而维持了它细胞内的一个低表达。那么进一步呢，我们就做了一个，就是我们如果把MIR30A重新给它导回肝癌细胞里，会发生什么样的情况？那么在肝癌里边，我们经常用的一个载体呢，就是肝星状细胞的外泌体，我们经常会作为一个载体。所以呢，我们也是拿 IX2 的一个外泌体，然后再把它转染了一个 CY3 标记的，就是MIR30A 的一个 mimics。那么我们看一下。它在哪个器官里面富集是最多的？那我们可以看到，就是它基本上都集中在肝脏。那么也就是说，为什么肝脏呢在外泌体中的研究是最多呢？那么我们通过鼠尾静脉，然后把这些外泌体打进去之后呢，我们看它基本上都富集到肝脏。它富集到肝脏呢，从而就可以达到一个治疗的一个效果。那后续呢，我们也是通过2种 model， 一种就是说。鼠尾静脉注射的一个肺转移的模型，另外一个就是皮包膜下注射肝癌细胞，然后就是肝转移的模型。我们是通过了几个模型来验证，然后我们就是说，模型造好了之后，我们再通过鼠尾静脉，然后再打入那个外泌体，然后再连续观察它的转移灶的一个情况。那么我们可以发现，就是我们外泌体治疗之后呢，它可以明显降低了就是肺转移和肝转移。那这个呢，我们基本上都是通过小鼠的核磁进行一个连续的一个观察，从而进行了一个动态的一个连续监测它的转移的一个情况。那么所以说呢，就是说MIR30A呢，就是说这种外泌体，然后包含这些就是抑癌基因啊，从而对于肝癌呢还是可以达到一定的治疗效果。而且我们发现MIR30A它进入到肝癌细胞之后呢，它反过来呢，它可以抑制呢外泌体的一个释放，从而达到了一个就治疗的一个正反馈的作用。我们也知道肝癌它外泌体释放少了，那么它肿瘤转移呢也是明显下降的。那么总体来讲呢，就是说，外泌体呢现在在肝癌中呢，就是肝癌中研究中还是非常多的，因为就是说我们通过静脉给呢。他们就发现，在人体呢也是在肝脏富集的。通过动物实验呢，鼠尾静脉给呢也是在肝脏中富集的。所以呢，在肝脏的其他的疾病，包括肝纤维化、脂肪肝以及就是NASH啊这些的，都是研究非常多的。因为它可以在肝脏富集，然后有这个特性。那么当然呢，就是说现在外泌体作为一种治疗方式呢，就是说，因为大家以前研究的都是说它作为一种诊断的一个 biomarker。现在作为治疗方式呢，还是处于一个起步阶段。但是我们想，就是说因为它有它自己的先天的一个特性，因为它是那个脂膜结构，所以它是更容易进入到细胞内。另外，它没有额外的一些像细胞移植的副作用，可能它治疗的潜能呢会更大一点。那么我们也想呢，它对于就是生物制药来讲呢，也会是一个非常好的一个领域。那这是我的 team， 也非常感谢大家，谢谢。
好，谢谢刘教授的报告。大家有什么问题？一个简短的问题，简短的回答。
那个非常好，刘教授讲的非常好。那个就是说，关于外泌体方面，我们说刚才讲了，肿瘤也是非常非常多的应用的。那肝病它是一个新的方面，那就是说，比如说肝癌。我觉得肝癌它有些细胞功能是障碍 T 细胞功能，包括在肝病方面，如果外泌体好像对这个提高 T 细胞的功能，应该说是在肿瘤方面上有些应用。那在肝病方面，比如说肝癌啊，或者乙肝啊，或者一些T 细胞功能有没有这方面的尝试呢？谢谢。
谢谢您。在肿瘤中呢，关于外泌体对于免疫调节呢是研究非常多的，而且就是说它主要呢还是可以发挥免疫调节的作用，然后包括调节 T 细胞啊，调节巨噬细胞。但是在其他的肝病中呢，相对研究的比较少，但是肿瘤中呢还是研究特别多，尤其是它可以增强那个 PD-1 的一个疗效啊，就免疫治疗疗效，目前这样的文章还是比较多的。而且我们前期呢也发现，就是靶向治疗联合免疫治疗中呢，也是外泌体发挥了更多的一个重要的一个作用。如果我们把伦伐替尼撤除，那么实际上就是那个我们把那个肿瘤细胞撤除，伦伐替尼它对于巨噬细胞的一个就是 M2 向 M1的一个转换就没有了，所以还是细胞之间的相互作用的外泌体发挥了比较重要的作用。
好，谢谢刘教授。下面一位季东教授是 online， 是用中文还是英文啊？一会儿我也不知道了。
Online.
Online, good.
Yeah.
Now I would like to invite Dr. Liu from PRA General Hospital, 5th Medical Center. Today, his topic is about the utility of elastography in the diagnosis of portal hypertension related complications. Dr. Ji, please.
Okay, thank you, Professor Jia. Good afternoon. It's my great honor, a great pleasure to introduce our studies about performance of liver stiffness measurement for portal 1 hypertension and its complications. As we know that chronic liver disease experience hepatitis, liver fibrosis, portal 1 hypertension, liver cirrhosis, even liver failure or hepatocellular carcinoma. Actually, liver cirrhosis and portal 1 hypertension are mortally causalities. Diagnosis of portal 1 hypertension can cause timely treatment, accurate prediction, and efficient monitor for patients of cirrhosis. With regard to progression of portal 1 hypertension, the most dangerous and common complications were esophageal and gastric viruses, or even bleeding. Ascites followed by spontaneous bacterial peritonitis. So if we can predict these complications in advance, we can make a more accurate therapeutic strategy and improve the outcome of patients with cirrhosis. What is the ideal non-invasive assessment? It should be simple, economy, safe, easy to operate and accept with high sensitivity and specificity. Also, it should have less impact factors. Now let's look at the gold standard of portal 1 hypertension. It is hepatic venous pressure gradient, HVPG, which is an invasive procedure and hard to accept it by patients. For diagnosis of EGV, gastroscope is uncomfortable for patients and time consuming for physicians. So non-invasively, liver stiffness measurement is associated with various liver fibrosis stage. In our studies, we aimed to predict esophageal and gastroviruses and its complications more sensitive and specific by combining LSM with other serum parameters. This is the first study. In this study, we retrospectively analyzed compensated cirrhosis patients who had presented to our hospital from January 2014 to July 2020 with complete clinical data of biochemical tests, gastroscopies, and liver stiffness measurements. Patients were divided into EGV group and non-EGV group by gastroscopy. Patients after analyzed by multivariable regression, logistic regression, we can establish a novel prediction model for EGV. Totally, 350 patients were enrolled. Among them, 225 patients were without EGV, and 125 patients with EGV, diagnosed EGV, but all of them had no history of bleeding. There were a significant difference on the PLT, spleen diameter, and LSM between these two groups. We did not observe differences on WBC, AST, ARB, portal 1 diameter, and the child pill classes. The top is the calculating formula based on above analysis. This normal model was named as ELAPSE with AURC of 0.83, which was significantly higher than its components, LSM, PLT, and the spleen diameters. In addition, we also compared ELAPSE with other serum models, such as APRI, FAB4, and GPRI. Our ELAPSE APRC is the highest among these well-known models. Next, we will use the ELAPSE to predict the EVG in the prospective study for external validation. This is also the study which is attending the CHESS multi-center study guided by Professor Qi Xiaolong, aiming to acquire more reliable results and solid conclusions. This is the second study focusing on the ascites prediction. Totally 650 patients were enrolled. Among them, average age was 45 years. 76% were male, 28 were ascites patients. The median LSM of patients with or not ascites were 45 or 19 kilopascal. The AURC of liver stiffness measurement for predicting ascites in patients with cirrhosis was 0.895. The cutoff value was 27.7 kilopascal with specificity of 81%. Sensitivity was 88%. This study indicated that the high LSM value is a predictor of ascites in patients with liver cirrhosis. This is the second study for prediction recurrence of HCC. Firstly, liver cirrhosis or HCC patients with a chronic hepatitis B infection were retrospectively enrolled and were divided into training cohort and validation cohort randomly in a 2-to-1 ratio. Second, the high risk factor for HCC were screened by logistic regression on training cohort, and scores are assigned to different parameters in the equation to generate a non-invasive early warning model. The performance of this new model was analyzed by ROC to produce the cutoff value and its sensitivity and specificity. Finally, this score was evaluated in the validation cohort to demonstrate its applicability and reproducibility. Totally 321 patients were enrolled. Results showed that age, LSM, and alpha fetoprotein was the independent risk factors of HCC. This new early warning model named as ALA was calculated by this formula. The AURC of formula of ALA is significantly higher than age, LSM and alpha fetoprotein alone, using the cutoff value of 9.66, the sensitivity and the specificity of LA was 86% and 82% respectively. This study was reserved by the ASLD 2018 for oral presentation. Now we are enlarged the sample size to 600 patients and collaborating with Professor George Liao and Professor Mata as a multi-center research. We are hoping good results and publications. Summarily, HVPG is the gold standard for the diagnosis of portal 1 hypertension, but its clinical application is limited. Non-invasive assessment provide very convenient means to the diagnosis, treatment, and even prognosis of portal 1 hypertension. Our study based on the liver stiffness measurement determination. It is combined with other parameters can improve diagnostic accuracy and specificity. All of study was under the guide of George Lau. Thank you for your listening. Thank you.
Thank you. Maybe one question again. We have some time for one question. Yes, Dr. Qi.
Hello. Yes, I'm listening.
Hi, Professor Qi. I have one question for your first study. So you mentioned for a new formula with the spleen diameter, platelet, and liver stiffness. You call the ELPS. Yes. Model, but you know, LSPS is more recommended by the Baveno criteria. So have you ever tried to compare with LSPS with your new models? Because in your comparator, I didn't see the LSPS there.
Yes, thank you, Professor Xiaolong. It's a very great question. Actually, we compare the LSPS with our new ELPS model. The ARC was similar. So this is a part of your study of multi-center research. So we hope we can make more solid and reliable results from multi-center research. Yes, it may have a high performance than LSPS. Thank you.
Okay, thank you.
Thank you.
Okay, thank you. Very good. Now, last but not least, I would like to invite Professor Chen Jinjun to give a talk on the non-invasive assessment of high-risk varices. Professor Chen, please.
Thanks very much, Professor Jia. And my name is Jinjun Chen. My topic is about the non-invasive screening high-risk varices in HBV patients. As we all know, the antiviral drugs, tenofovir or entecavir, is very easily to be accessed in China or worldwide. So currently, the liver cirrhosis is taking the center stage of the HBV infection, let me say, because liver cirrhosis will cause very fatally complications, acute variceal bleeding, hepatic encephalopathy, ascites, and acute and chronic liver failure. So, and for acute variceal bleeding, how to prevent, how to screen, and how to regress. So the most widely used surrogate marker is the high-risk varices. How to define this? And then Baveno 6 consensus, they define the high-risk varices is, equal to the varices need treatment with the NS non-selective beta blockers or otherwise. And then clinically, it's predominant by the esophageal varices. For the gastric varices is not so common. And under the endoscopy, in compensated cirrhosis patients, high-risk viruses include esophageal varices grade 2 or 3, or some patients with a grade 1 varices. I mean, if we can find the red whale mark, the plus red whale mark, we can, I mean, say it's high-risk varices because they have a higher risk for bleeding in the next years or months. I mean, currently, Bovino 6, it provides a very simple criteria to screen high-risk varices. That means in compensated liver cirrhosis patients, if the liver stiffness measurement less than 20 kilopascal and the platelet count is over 150,000 per microliters, then the patient can, I mean, avoid the endoscopies because the high-risk varices can be safely ruled out. Right now, the missing rate of the HRV is required not over 5%. That means the missed HRV divided total HRV. Okay, and for the current Bovino 6 criteria, it can avoid endoscopy around 30%. But the key question is, all guidelines, international or national guidelines, recommend the immediate antiviral drugs for the liver cirrhosis patients. That means liver stiffness over 10 kilopascal or radiologically or histologically diagnosed liver cirrhosis or in decompensated cirrhosis patients. So the real clinical scenario is that all liver cirrhosis patients caused by hepatitis B is under the antiviral drugs. Just like Professor Yu talked that liver cirrhosis can be regressed, can be reversed under anti-HBV drugs. This is a tenofovir, this is a entecavir. But if we look at the liver stiffness measurement, it declined rapidly under the antiviral drugs. This is a result from the Hong Kong University. The right is from the Professor Jia and Professor Yu. And this is from the joint work from Professor Ho